ISR Symposium 4. Just to mention, just to state that this is a certified course, and at the end of the today's session, you'll be able to download the certificate. So we encourage you to stay till the till the end of the program. Today's discussion is going to be very important, and it's going to address a certain area, especially when we talk about male infertility, and all our speakers will be navigating through that journey. I look forward to this engaging discussion. To set the tone, it's my pleasure to introduce our convener, Dr. Monica Singh. She's a trailblazer in the field of reproductive medicine. She currently serves as president-elect Bhopal Ops and Gynec Society, founder president of ISOPAP Bhopal Chapter 24 to 27. She is a national executive member of ISAR from
It's okay,
24 to
Priyanka.
27.
It's okay, Priyanka. I think we move on, huh?
Yeah.
Because President SR is there, so we should not
All
waste.
right, over to you, ma'am.
Yeah, thank you. Thank you so much. And a warm welcome to President ISAR, Dr. Amit Patki, sir, who has just joined. Sir, we are honored to have you in the program. This is the 4.0 episode of ISAR Perfection Fertisphere, where our tagline is precision, practice, and perspective. And we've already done 3 webinars. This is the 4th scientific symposium. And today it is on male infertility, navigating the journey. The journey, as perilous as it sounds, has got many silver linings in the clouds in the form of recent technological advancements. And stalwarts are speaking about all these advancements as well as the basics. Just now, Dr. Viren Shah told me that, Dr. Monica, we are speaking on things like CASA and the futuristic aspects and neglecting the basics. But here, our very first lecture is on basic semen analysis by none other than Dr. Rupin Shah, followed by President ISAR himself, Dr. Amit Patki, who will be taking a talk on azoospermia. And this is followed by the very, very vibrant team of Sunil Jindal and Dr. Dipankar Banerjee, who will be conducting a panel on different case scenarios of male infertility, which, sort of confuse us time and again. So without wasting time, I take extreme pleasure in welcoming all of you and our dignitaries to the stage. And can I have slide of President ISAR, Dr. Amit Patki, please? I've already walked you through the program. And Dr. Amit Patki is the face behind ISAR India right now. He is heading the largest organization of reproductive medicine specialists in India, comprising clinicians as well as embryologists. Sir is the medical director of Fertility Associates Mumbai, consultant at Khar, Hinduja and Surya Hospitals Mumbai, President ISAR 24 to 26, country representative Aspire 21 to 23, Governing Council member of ICOG from 12 to 21, Vice Chair MSR 23 to 25, Chair West Zone RCOG 2015 to 2020, and President Mumbai OBGY Society 2014 to 15. Dr. Patki has given as many as 50 publications in national and international journals, written 100 book chapters, edited 3 books. He holds 2 international patents in infertility and stem cell research and is a renowned TEDx speaker. So we are so honored to have you amongst us, and we'll be, so happy with your words of blessings.
Thank you very much, Monica, and a very good evening to all of you. I must congratulate this team who has always come up with innovative topics and excellent speakers. And I look forward to listening to the speakers and the faculty. So congratulations once again, and I'm eager to join and listen to our first speaker, Dr. Rupin Shah.
Thank
Thank you,
you.
sir.
Thank
Thank
you.
you, sir.
Thank you so much, sir. And sir is the driving force which led us to restart perfection in a different platform at a different time with a little bit of gap. And he is the person who encouraged me right from Isar Lucknow that you should start perfection again. So we did it, and we have, our team members, 3 lovely managing committee members with us, Garima Sharma, Neelam Dise, and Manisha Bajpai, along with my team from Bhopal. So, sir, I'll be forever grateful for this opportunity you have imparted us.
Dr. Monica, I'll add to this that Amit Patki sir, last 20 years, I'm with him with in national international conferences, and the male infertility is the topic which touches to the heart of the sir. So anything we have done jointly, many studies also, sir, national level, which has been published in the international journal. So I think for this, he's the best person from the India to give a justice to this topic, male infertility. Thank you, sir. Welcome, sir.
Thank you, Dr. Randeep. And now our chief guest has joined. Now welcome, Nandita Madam, for joining from the holy city of Haridwar, where Madam is there for a Foxy program with Sunita Tundalwadkar Madam. Another person, this is a team, this is a great team of Nandita Madam and Sunita Madam who actually, laid the seed of this huge tree of ISAR perfection way back at the time of ISAR Bhopal. When we finished the conference in ISAR in Bhopal, the 27th annual ISAR, it was in March. We talked about this, series, and April we launched ISAR Perfection, the first season. So thank you, Nandita ma'am, for joining. And just before Nandita ma'am is welcomed formally, we would like to play a message from our Secretary General ISAR, Dr. Asha Anil Bakshi, who is holding the very important post of Secretary General of this large organization. She is a very active academician and heads the Asha Bakshi Fertility Center, Motherhood Hospital, Indore. Is also very active in Foxy, has been the vice president of West Zone Foxy, held many key posts in MP IAG, MP ISAR, and done wonderful conferences in Indore, recipient of several national and state awards. We'll play the video sent by Dr. Asha Bakshi. Anmol.
A very good evening, all. First of all, I would like to congratulate Dr. Monica Singh and Dr. Randir Singh for successfully doing this fourth episode of Perfection Fertisphere series. Today, the topic selected is really very good, male infertility navigating the journey. And we all know that with increasing awareness, technology and acceptance, infertility is getting its due respect, and now lots of discussions are going on. And today we have a great chief guest, and that is our Queen of Hearts, Dr. Nandita Palshitkar. I welcome her. At the same time, I would like to welcome Honorary Dr. J.M. Kanand, my dear friend, Dr. Archana Basir, who are the guest of honor, and our special guest, Dr. Virendra Shah, who is from Indore. So, welcome. And any program is not possible without a young supporting team behind it. And for that, I would like to congratulate and thank the young brigade, Dr. Garima Sharma, Dr. Neelam Bise, and Dr. Manisha Bajpayee, and also Payal, Pooja, and Shweta. So I hope that this CME is going to be great, and especially when you have doyens in the field of infertility. I would say Dr. Rupin Shah, who is the father of male infertility in India, and especially he has helped so many men father their child with their own sperms, even in the most difficult situations where he has offered micro TSA. And Dr. Amit Patki, who is going to tell us that what to do when an azoospermic man comes. It is not AID anymore. There are so many things to do. So I'm sure this is going to be a very enriching experience. So wishing you a very happy journey towards the wisdom and knowledge of male infertility. Thank you so much.
Thank you, madam. Any program is illuminated and glorified by the presence of a very important person, that is the chief guest. And I will be forever thankful to, I'm always, every day of my life, I'm thankful to Nandita madam, but today I'm specially thankful because past President Isar and past President Foxy is right now having a Foxy meet in Haridwar, but all the way from that beautiful city next to River Ganges, madam has joined us. And madam, I know that you are in the middle of so many things. The whole of India, all of us know you, adore you, and respect you immensely. And madam, we welcome you to this program as our chief guest. an eminent person in the scene of reproductive.
Thank you. Thank you, Monica. Thank you so much. I think it's really a pleasure to be with you and Randhir. It's always some excitement, there's something new, and a lot of learning. I must congratulate Amit on his fabulous year. He's been doing a great job, and I think male infertility is something very close to his heart also. And Asha for saying those beautiful words, and Jayam and Archana Baser, who are co-guests with me. So, male infertility is really something that is, changed a lot. And actually, if you look at it, the progress made in male infertility is very limited to the lab because male infertility did not exist till 1860s, I mean 1960s. In fact, the first paper on semen analysis was published in 1957. And that time people knew that, okay, male infertility existed. So obviously the research, everything that was done, we really cannot treat it naturally. Okay, we need to use the laboratory to treat it. So this is where I think the wisdom comes in. Did
Madam,
not the male infertility did not exist. So definitely with that little trivial trivia, I think I would just congratulate you all. It's a superb topic, and I'm sure you're going to discuss even artificial intelligence and all the new programs and the robo ICSI and stuff that has come in. And it's really an exciting part to be, it's very exciting to be in infertility management right now. So happy learning, enjoy, and remain as passionate. And oh gosh, Rupin has come on stage. I mean,
And
he and me
Nandita,
have
what
been
a
working
lovely
so much.
picture.
Yeah,
Welcome,
I
sir.
mean,
Welcome, sir. Welcome.
male infertility cannot be complete without Rupin.
Yeah, yeah,
Rupin,
ma'am.
welcome. It is fantastic to see you.
Yeah.
And I think that's great that you and Amit will be tackling this subject. Thank you for inviting me over here. It's really a pleasure. And I'm sure we'll learn a lot of new things. Thank you.
thank you. Thank you, Nandita.
Thank you,
Thank you,
Nandita.
Nandita, ma'am. Thank you, ma'am.
Thank
And
you.
hello from the land of the Ganges. I did Ganga Snan, so I'm being purified, totally purified,
So do
ready to
one more
sin
for me
again.
also.
For all is
I
Okay,
know.
Amit, done for everybody.
yeah, yeah,
I
That's
don't know
good.
if you can see this. This is the Ganges.
Yeah, so
Mm.
beautiful.
I
I
know.
don't know if you could see it.
yeah, yeah. Glimpses, yeah,
Wonderful
Ganges.
place. Missing all of y'all, but definitely all the best. All the best.
Thank you. Thank you so much,
Thank
ma'am.
you, ma'am. Thank you, ma'am.
Enjoy Haridwar, Nandita.
Hmm.
Thank you, ma'am. We could almost feel the breeze of River Ganga coming over us, you know. So now we move on to our guests of honor who are there to bless us and impart their words of wisdom to us. We have Dr. Jayam Kannan, ma'am. Madam joined dot on time, and even before time, she was there. Madam is also in Haridwar. Madam, can I have Madam CV, please? Dr. Jayam Kannan is a mentor figure and a mother figure to most of us. But many of the youngsters don't know that Madam has been the emeritus professor at Tamil Nadu MGR Medical, a very acclaimed university in Chennai. She has held the prestigious post of Vice President Foxy India 2018, and she has been the free legal aid. She's started a free legal aid center for women in Trichy since 1992. Very passionate for women's health as well as women's well-being. Also, she has been a member or partner in Maternity Child Health WHO since 2008 and a certificate course in reproductive medicine FOXY. Madam started 2012 to 2024. She won the
Thank you,
President of
Monica.
India Medal. Ma'am, this is so nice, ma'am. President of India Medal for outstanding
Thank you.
performance in MBBS, winner of 13 medals and prizes in MBBS. Madam, that must be a record. A national lead assessor with exceptional commitment, a very encouraging person, always has a positive word for everyone. And ma'am, we are thrilled to have you amongst us and like to have a few words from you, ma'am.
Thank you.
Welcome, ma'am.
As
Welcome, ma'am.
thank you. As Nandita said, greetings and blessings from River Ganges, Maya Devi, Chandi Devi, Bharat Mata, and Anjanai Devi from the Haridwar city. As we are at Uttaranchal, the gateway to Himalayas, we also feel the reverberating changes coming to us as soon as we land in the airport itself. This topic, which has been given to a this thing, small creature, which ever tries to keep itself vibrated. But still, we, in the last 5 decades, even though we have tried our level best, we still have a long way to go to do in vitro maturation of sperm. We can do in vitro maturation of the oocyte, but in vitro maturation of the sperm is still a longing subject. Of course, as Nandita said, right from 1960, we have been looking at the microscope for the sperm with so many characters which have been described. Of the lot, the one which is remaining ever is the Kruger's criteria. By extra, all those things are coming and going and going and coming. The two, apart from our own Rubin, we have William Omelette and Dr. David Mottmeyer in Australia, who have been giants in working on sperm right from 1970, because my career dates back to 1970. In 1998, with the arrival of sildenafil, we started categorizing the men with sildenafil positive and sildenafil negative as this comes to erectile dysfunction. These were all the centuries of the past. And in the century of the present, we have the artificial intelligence which is able to give us a big turn in our infertility care, especially towards the male gamete. And I'm sure the upcoming youngsters, including all my children, my daughter and daughter in law who are in the field of infertility, I hope you all will have a standing, reassuring change towards making the sperm get itself made and allow the man who has got poverty among plenty to be settled well. Thank you very much. Over to the organizer for your able, energizing work. And I'll be still hearing whatever you are saying so that I boost my energy with your recent knowledge also. Wish Monica, as a managing committee member of ISAR, doing such a wonderful work. I really appreciate you a lot. Grow more is the one word I can tell you. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you. Thank you.
Thank you, dear ma'am.
Thank you.
And
Thank you.
thank you for your blessings. And next, I would like to introduce our guest of honor who is amongst us from our own state of Madhya Pradesh, Dr. Archana Baser. Dr. Archana Baser, like Dr. Bakshi ma'am, has held many posts in all the various organizations of gynecologists in India. Madam was the vice president of Foxy in 2020. She's done the wonderful AICOG 2021 in Indore, in which she was organizing secretary. Madam is fellow representative, very active in RCOG West Zone, and is the Imaging Science Committee chair of CEFOG. She's also held the post of chairperson Foxy Imaging Science Committee in the years 2015 to 17, organizing secretary of the very successful ISAR 2016, and the managing committee member of ISAR, IAGE, and ICOG. Her hospital holds the record for removing the largest uterine tumor. I think it was a fibroid, ma'am, or
Yes,
wait,
yes, it was fibroid, Monica.
fibroid. And she's also always making headlines all over the country with her dynamism and with her optimism. Madam, the stage is all yours. Welcome.
Thank you, Monica, and for inviting me and having me on this platform of Perfection series, which you have been doing so successfully. And I think I'm really proud of you and Randir for is starting it from the MP after ISAR, which was done in Bhopal. And I think a lot has been talked about the male infertility, how it evolved, and how still lot to be done. And I'm really happy to share the platform with Dr. Nandita, Dr. Jayam Kanan, Dr. Amit Patki, Dr. Rupin Shah, Dr. Bakshi, and all the managing committee member of National ISAR, Garima, Dr. Bise, and all of your panelists. I think it's going to be a great, great webinar and I'm here to listen to you because male infertility is a subject which is not talked about much, but we really need to remain updated because still there is a scope for learning and improvement and research in this field. So it's a very focused topic which you have taken, Monica, which really makes your series very interesting and very educative. So I'm really congratulate you and all the best for this webinar. And thank you for having me here on this platform. And all the best.
Thank you,
Thank you,
Archana ma'am.
ma'am. Thank you, ma'am.
Best wishes for your future endeavors, madam. We
Thank
all
you so much.
are.
Thank you so much. I'm going for President Foxy 2026. So thank you very much for your best wishes.
Thank you, ma'am. Best wishes, ma'am.
Thank you, ma'am. And now, before handing over the session to Neelam to introduce our special guest, Viren Shah, sir, I would like to acknowledge the presence of Dr. Mitra Saxena amongst us. Madam messaged me in the morning that, Monica, you must remind me. So I said, Madam, you must join with the faculty link and be amongst us. We congratulate Madam for winning the very closely contested VP election of North Zone Foxy, and she is VP elect now. Congratulations, Mitra ma'am, and thanks for joining us. Over to you, Neelam, for introducing our
Thank
special guest.
thank you, Monica Madam. It is my special honor and privilege to introduce Dr. Virendra Shah, sir. He is the most senior embryologist of our country. He's been working since 1987, and he has many first to his efforts, including first IVF baby of MP. He has also held various posts in ISAR, including Honorable Joint Treasurer of ISAR, Executive Committee member. He has been Chairman of Special Interest Group of Embryologists ISAR since last 6 years, and we really look forward to hear from Dr. Virendra Shah, sir.
Thank you. Hello, can you hear me?
Yes, sir, we can hear
Yeah.
Yes,
you.
And thank you for inviting me in a perfect series of the ISAR Symposia. And especially the day by day, the infertility is increases. The male infertility is also increases like anything. So the subject was chosen by the Dr. Bakshi, Monica, it was excellent. I won't agree. I'm not wasting the time. I will just finish my. I just congratulate the convener, Dr. Surya, Monica Singh, and Randir Singh, as well as co conveners. And I just thank you very much. And I'm waiting for the Dr. Rupin Shah's lectures.
thank
Okay.
you. Thank
Now
you.
I take pleasure to introduce and invite, of course, our own conveners, Dr. Monica Singh and Dr. Randir Singh. It would take a long time to just elaborate on the work Dr.
Oh,
Monica
Neelam,
Singh.
you just have 2 seconds
I'll
each.
just mention, yes, I'll just mention she is Vice President MP ISAR and she has held many posts. And I would take this opportunity to acknowledge and applaud the all inclusive and focused leadership Dr. Monica Singh is executing in ISAR. Hats off to you, madam. Dr. Randir Singh, please. Dr. Randir Singh is also founder governing council member of ICRM, Indian College of Reproductive Medicine. He has held many posts. He is a committee member for the surrogacy board also, and he has been very active all across India for various topics and publications. So it is our pleasure to work with you, Monica Madam and Randir sir. Over to you, Madam, for the next.
Yeah, thank you, Neelam. And now I would like to introduce our co-conveners. These are the pillars of the program with whom I work, and we make a great team, I think, because whenever any one is of them is busy, the other two and they pitch in, and we just ensure that we complete everything. And I'm always after them. They must be sick and tired of my messages right from the morning till night, but I think it's for the good of the program, and for ISAD we have to do this much at least. So I thank you, Dr. Garima. Can I have their CVs? Garima Sharma is, I remember her from the day I met her in Jaipur, and I was a judge, and she received the Manish Banker Award. So she struck me as a very not only beautiful but a very bright girl from Amritsar. So I also have studied in Amritsar, so we had that Punjabi connect. And at the same time, she is very chirpy. Then we've been meeting. We met in Eshre and we bonded after that. She's received several awards. She's very active. And the best thing is she's got a good, title for everything. She's very good with the words. So if there's something lacking in the program, some good words we need, she finds that exact word and completes the whole phrase. Thank you. Thank you so much, Garima.
Thank you, ma'am. Thank you, ma'am.
Next, I would like to welcome Dr. Manisha Bajpai. Dr. Manisha Bajpai is the embryologist managing committee member of ISAR. They all won the recently held managing committee election. So Manisha holds the fort of embryology section of ISAR Perfection series, where she's responsible for introducing us to wonderful academicians from all across the embryologists of the country. And she has got a very good bonding with them. So sometimes there are people who don't want to join, but she'll motivate them. She'll get them in the program, get them to talk, participate. So that is her USP. Thank you, Manisha. Manisha is at present in ACE in Bhubaneswar. And next, I would like to welcome Dr. Neelam Bise, again, a very accomplished academician. With her addition to our family, we have found a big connect with the people. She connects very well. She talks to the very senior people as well as to the juniors, gets them, motivates them to join, brings out the best in people. And she's always watching, even if she's not active, we know that she's watching and she'll be there if anything is needed. So she is now the managing committee member of ISAR as well as the managing committee member of MSR, so also Garima. She is an accomplished, IVF course trainer. She's been the assistant professor at KEM Mumbai. So thank you, Neelam, for being there. Thank you. And next, I think, Neelam, could you introduce the, acha, I'll just go through the coordinators. Our coordinators are there from Bhopal. We have Dr. Payal Raghuvanshi and Shweta Agarwal. They are fertility consultants in Bhopal in the private sector. And we have Purva Bhatkur, who is assistant professor at GMC Bhopal. So from medical college also, we've got a good connect. And we get lots of inputs from our coordinators back in Bhopal. Thank you so much, girls, for being there. So now we can formally start our webinar with the first talk, much awaited first talk. So Dr. Neelam, do the honors, or Dr. Garima? Who was it?
Garima, please.
Garima. I'm sorry. Garima, please start the session one. Yeah.
I think no topic can have its own justice if we don't remember, go back to our basics. And that's when I was trying to reach Dr. Rupin Shah and I was pestering him, sir, please give me a topic. And it really gave me an awestruck when Sir came up with a topic like back to basics, understanding semen analysis report, something so important for clinicians from every parameter that's reported in the semen analysis. And we are eagerly awaiting to listen to this talk by Dr. Rupin Shah, who is the microsurgeon and consultant andrologist at Leelavati Hospital, Mumbai, and I would say the pioneer for male infertility in the country. May I request our chairpersons for this session can I have the CVs of our chairpersons? Dr. Vaishali Chavan, she's the clinical director at Cloud9 Hospital in Pune and director at Sanvi Clinic Women's Health Center. She's also the vice president of the Pune OBGY Society for this year, and she has been the past chairperson for Perinatology Committee FOXY. She has had several publications and contributions in the book chapters and has received some very important awards to her credit. I welcome you, Dr. Vaishali Chavan.
Dr. Garima.
Can I have the next CV, please? Dr. Richa Singh, Professor and Head of Department of the OBGY Department at SM Medical College. She's currently the President of Agra OBGY Society, Vice President of Indian Menopause Society. She has been the Organizing Secretary for UPCon in 2025. And she's something, a very beloved award any teacher would receive is the Best Teachers Award by the students of SM Medical College, Agra. And again, a lot of awards to her credit, right from Kamini Rao Inauguration at AICOG 2010 to Foxy Korean Research Award in 2012, and a lot of research papers to Madam's credit. I welcome you, Dr. Richa Singh. And our third chairperson is Dr. Jyotsna Dowle. She is the director of the Dowle Hospital and Matrutva Test Tube Center at Ahmednagar, and somebody who is known to have the first IVF center, the first test tube baby, and the first ICSI baby born out of the frozen embryo transferred in Ahmednagar. And she has been the past president of AMOGS 2016 at Shivdi. I welcome all the chairpersons, and I hand over now the stage to you all to introduce our esteemed first speaker for the day.
Thank you, Dr. Garima, for a very kind introduction. And let me express my gratitude to Dr. Monica Singh for inviting me to be here on this very special webinar with such esteemed faculty. And thank you to Dr. Randhir Singh, Dr. Neelam Bise, who had called me to invite. And it's indeed a great honor to chair a talk by none other than Dr. Rupin Shah, who is truly a legend in the field, a greatest visionary. And giving a formal introduction about Sir, can we have Sir's formal introduction? CV?
Anmol?
So, Sir, as we know, is microsurgeon consultant andrologist at Lilavati Hospital, Mumbai. And he has been doing revolutionary work. And if you can just display Sir's...
CV, please. There is a CV.
So it's truly an honor to chair your talk, and we are really looking forward to hear from your greatest words of wisdom, and it is truly an enriching experience that we'll be here to listen to you, sir.
Sure. I think we can skip the slide, that's okay. And I'll start my talk instead. So if you can allow me to share, we'll go on to the talk.
Sir, just a second. I think they have some technical thing.
Doesn't matter.
No, sir. We would like to have your CV in front of us. Yeah.
Yeah. If I can go, if I may go ahead, Sir is MS in General Surgery, MCH Urology, and he's the first urologist from India to have undergone training in male reproductive microsurgery at Belgium, and he's a leading expert in microsurgical VA and vasectomy reversal, varicocelectomy, and so on. He's associated with many IVF centers, and he has vast experience in sperm retrieval and micro dissection tests and so on. And Sir has developed Shah penile prosthesis, which is commonly used penile implant in India, and he has been delivering many orations, has received many awards, including the prestigious Dr. B.C. Roy Award from President of India. He's a founder president of South Asia Society of Sexual Medicine and super advisor to Global Andrology Forum. And Sir has published extensively with many chapters, and he's associate editor of Fertility and Reproduction Journal. And Sir has been conducting a highly popular annual andrology training program since the past 30 years. Welcome, Sir.
Thank you very much for that warm introduction. Thank you, Dr. Monica Singh, for the invitation, Garima for our correspondence, and to the chairpersons for their warm introduction. If we can stop sharing, I'll start sharing my slides. When I first gave this topic, which was back to basics, I'd originally thought of discussing the usual parameters. And then I realized that this was a session on perfection, which would then make it more appropriate to talk on some aspect of semen analysis, which is of relevance to everyone from the young specialist to the very experienced specialist. And just as I was contemplating what to talk about, I had two referrals from colleagues. Rupin, please manage this man. He has normal count, normal motility, but morphology is only 1%. Two referrals in one day, and I realized that this was a sign that the topic I need to speak on today is one aspect of semen analysis, and that is teratozoospermia, because this is one area where I find that there's a lot of confusion, whether it is the embryologist, and I see many of the embryologists in the audience, whether it is senior IVF practitioners, many of whom I work with regularly, or even the juniors. 2% normal, 1% normal, what shall we do? So this is the kind of report that often the patient will bring. Volume is very good, concentration is excellent, rapid forward is 26% excellent, but morphology 2%, 3%, 1%, or 0%. And the patient brings this report in a great state of panic, convinced that he's going to give birth to a double-headed child. The gynecologist has told the patient with 2% normal morphology, you cannot conceive naturally, IUI will not work, IVF also no, perhaps ICSI, but ICSI will also have a low chance of success. And today we're going to ask whether this is really true. Are these so-called evil sperm really the cause of the couple's infertility? Or is something else at work? And the reason why we thought that perhaps there is something wrong is that we see these men with isolated, severe polymorphic teratozoospermia, and their medical history is normal, their physical examination is normal, there is no gonadotoxic factor present. So where has this abnormality come? So looking at this, we decided that we're going to conduct a study, and I'm going to share that with you, that and several other studies which will discuss what have been actual clinical experiences with men with very poor morphology. And then we are going to explain the very surprising findings of our study and of the various studies that have been published in the past few years. So this was one study that we conducted at one of the centers in Dubai that I work with, Fakki IVF, large center, 5,000 cycles per year. So with Dr. Lamia, who is one of their senior consulting IVF specialists there, we decided to look at last 8 years data. This was a couple of years in publication, so the data is till 2022, large number of cycles. And basically the outcome of IUI was correlated with men whose semen morphology by strict criteria was normal, which means 4% or more than 4%, which had moderate isolated teratozoospermia, that is 2 or 3% normal, and severe terato, which meant either none normal or only 1% normal. And these were subjected to a number of statistical analysis, but we can focus on the box at the bottom left. And that shows that the bar to the left is normal morphology, and the middle is moderate teratozoospermia, and to the right is severe teratozoospermia. And there is a small decline in the IUI pregnancy rate in these three groups, but it did not reach statistical significance. And even when morphology was only 1% or 0% normal, there was still a 10% pregnancy rate. We flipped the data around, and here you can see to the left, patients with normal morphology, to the right, patients with abnormal morphology. And this is categorized then by the motile sperm density. The blue bar is those that have normal post-wash total motile sperm density. And the gray bar is those whose total motile sperm density was less than 9 million. And if you look at the blue bar to the left and the right, you can see that whether the morphology was normal or abnormal, the conception rate per cycle was virtually the same. On the other hand, whether the morphology was normal or abnormal, if you look at the gray bars, where total motile sperm density was low, the pregnancy rate was significantly lower, suggesting that currently, with the current strict criteria, and I'm emphasizing that because I'm going to talk about that further, apparently morphology does not predict IUI outcomes. And if you look at meta-regression of all the parameters, starting from the top bottom, you can see the first bar, whether morphology was severely abnormal, 1% or less, or normal 4% or more, you can see the midline is crossed. There's no statistically significant difference in outcomes. The same holds true for moderate teratome versus normal. If you go down to the bottom, female age, in fact, is a predictor significant of outcomes. And below that, you see post-wash total motile sperm concentration, which is also a predictor of outcomes. So what we found in our study, therefore, was that morphology did not matter. Now, is this the only study? No, this one is from Ranjit Ramasamy. Most of you know him and have heard of him. Very, very prolific writer in all aspects of male infertility. They did a study a few years ago. They did not distinguish between severe versus moderate teratome. They just had two groups, those more than 4% normal and less than 4% normal. Again, they looked at IUI outcomes and they found that the pregnancy rates were the same. Of course, you have to note the time frame. I'm going to come back to that again. Now, let's look at it from a different point of view, that if morphology doesn't matter, does that mean that even fertile men have abnormal morphology? And here's a paper from Fertile Study just last year. 68 men came for vasectomy, so proven fertility. More than 50% of them had a morphology of only 3% or less, though more than 90% of them had normal count and motility. And in fact, two of these men, that's about 4%, had 0% normal forms, even though they had impregnated their wives and were actually coming for a vasectomy. And this is not the only study. If we go further, here was a very interesting study, again, Larry Lipschultz, one of the pioneers in male infertility. And they looked at 24 men with 0% normal forms. And 30% of these men, almost 1/3, could achieve a pregnancy without the need of IVF, either naturally or with IUI. That was lower than the pregnancy rate of those who had normal morphology, which was 55%. But the point is that even with 0% normal morphology, 30% of these men achieved a natural or IUI pregnancy. So what all this data is telling us that we don't have to worry about morphology. Something strange is happening, and that even though morphology is poor, IUI pregnancies, natural pregnancies are continuing. What about IVF and ICSI? Does morphology impact IVF? Does it mean that if there's poor morphology, we should not do IVF, only do ICSI? Is ICSI compromised? So here was again a large study, retrospective, so that was a limitation, but the numbers are huge, more than 2,000 in each group. IVF cycles, ICSI cycles, and they compared the fertilization rate and the pregnancy outcome differentiated by morphology. More than 4% normal, less than 4% normal. And interestingly, this is what they found. In the IVF group, 2,200 patients, even when morphology was abnormal, there was only a marginal decline in the embryo quality, 58% versus 60%, not really very significant difference, and a slightly lower pregnancy rate, which did not achieve statistical significance. For the ICSI group, it made no impact at all. So poor morphology, a very marginal impact on IVF, not so on ICSI. So therefore, it brings us back to our fundamental question that does morphology really matter? And here in our paper, we did a very interesting analysis. We started by acknowledging that, yes, there's enough data showing that poor morphology correlates with increased sperm DNA fragmentation, with structural abnormalities, aneuploidy, etc. But at the same time, when morphology is assessed by the 5th or the 6th edition of the WHO manual, and I'm emphasizing that because I'm going to come to that, it does not predict fertility as we have seen in all these studies. So what is going wrong? If you step back for a moment and look at all the 6 editions of the WHO manuals, starting from 1980, and look at what was considered normal morphology. In 1980, as per the criteria used then, a fertile sample was supposed to have 80% normal forms. By 1999, when Kruger criteria were adopted, 14% normal was accepted, but in the 5th edition, 2010, and in the 6th edition, 2021, where very strict criteria were adopted, more than 4% or up to 4% was considered normal, which meant that as per these criteria, even a fertile male may have only 4 or 5% normal sperm, which is really, really strict, which leaves very little margin for error. And indeed, that is what happens. We analyzed 14 studies. The first 7 or 8 used the 5th edition super strict criteria. And if you look at the papers published, in none of them did morphology by super strict criteria correlate with clinical pregnancy. However, if you go back to studies published before the 5th edition, which means studies that used morphological criteria of the 4th edition, which were not as strict, then all the studies correlated morphology with clinical pregnancy. So what this is telling is that morphology probably matters, but how we look at morphology is critically important. Unfortunately, currently morphology has become so strict that it has lost the ability to differentiate between fertile and infertile. It's like a school teacher who fails every student in the class. The examination then has no relevance. So what does this mean for us as clinicians? Just one point which I need to make is all this refers to polymorphic teratozoospermia, which means that maybe 50-60% head abnormality, 20-30% mid-piece, another 10-15% tail abnormality. If you have monomorphic teratozoospermia, all sperms round-headed, all pinheads, all macrophagic sperm, this is definitely an infertile sample. But if it's polymorphic teratozoospermia, and that's what we talk about most of the time, what we are saying is that with the 5th and 6th edition criteria, morphology has lost its significance. So stop going into a panic. What we are saying is that maybe in the 7th edition, they will revise their criteria, but the current criteria are too strict to actually give us useful information. And nowadays, most IVF labs, the embryologists are all up to date with the WHO parameters. And therefore, almost all IVF centers, the reports will keep on saying 2% normal, 3% normal. But if the count motility are normal, the clinician's message is that this isolated poor morphology does not imply that that is the cause of the failure to conceive. It doesn't mean that this couple cannot conceive naturally. It does not mean that IUI is contraindicated. It also tells us that if the morphology is poor and if you want to do IVF, you could still proceed with IVF. You don't have to force the patient towards ICSI. And if you are doing ICSI, the isolated poor morphology does not mean that you're going to have a greater incidence of abnormal embryos or a lower outcome of pregnancy. So the take-home message here, and this is, I think, clinically very important to all the IVF centers, is that currently, the way your very well-trained embryologists are looking at morphology is actually too strict. So that if you have isolated polymorphic teratozoospermia reported by your lab, which is using the WHO criteria of the 5th edition or the 6th edition, you can ignore that and instead focus just on count, motility, and other parameters to take a clinical decision. So this was really the most important message I wanted to give today. Very briefly, I'm going to spend the next 5 minutes so that we don't run out of time to talk about one other important message from the 6th edition, which was published 4 years ago. Now, there are many new things in the 6th edition, and that's a whole lecture by itself. But the one point I want to focus on in the next 5 minutes is what I consider to be the most important change in the 6th edition, and that is the abandonment of the reference thresholds. The reference thresholds were derived by, so just stepping back, for the first, second, third, fourth edition, what was considered normal was by common consensus. They looked at some of the published papers and said, okay, as per this expert, this is normal, this is abnormal. In the 5th edition, they decided to make it objective and looked at the semen parameters of 1,800 fertile men who had achieved a pregnancy within 12 months of trying. This was then distributed into a data sheet, and the 5th percentile of this data sheet was used to differentiate fertile versus infertile. There were many areas that were not represented in these 1,800 men. So in the 6th edition, 5 other countries and another 1,700 men were added. And on the basis of this 3,500 men, new reference range was derived, again using the 5th percentile. Now, what was very interesting is if you compare the data from the 5th edition and the 6th edition, which you can see here, WHO 210 is the 5th edition, WHO 2021 is the 6th edition, you can see that the parameters are virtually unchanged. So that even though the reference population was doubled from 1,800 to 3,500, we can see that count, motility, morphology, marginal change, which means this data is solid. But having done this, in the 8th section of the WHO manual, they make this very bold statement, and which I'm going to read verbatim. The lower 5th percentile, which they first propagated as the cutoff between fertile and infertile, they say this lower 5th percentile of the reference population does not represent the limit between fertile and infertile. In other words, they're telling you that based on this, you cannot say that somebody with 14 million is infertile and 17 million is fertile. Now, this was a very bold step because over the years, we have seen again and again in published studies and in our clinical practice that men who are seemingly infertile are achieving pregnancy without a helpful neighbor, and men who are seemingly fertile with good counts are not succeeding. So why is this so? If you look at the data itself, we realize that they've taken the 5th percentile as the cutoff, which means that 5% of fertile men actually have semen parameters, count, motility, morphology, lower than what they consider as normal. But even further, if you look at the whole chart, look at the 50th percentile, which is what actually represents the majority of men, 50th and above. And you can see that the 50th percentile of the fertile population has a sperm concentration, sperm motility, sperm morphology, much greater than the 5th percentile, which is the so-called normal. Which means that if a man has semen parameters above the 5th percentile, even though you may say is normal, actually he could go from the 5th to the 10th, to the 25th, to the 50th percentile, and probably fertility will increase. And this was an interesting study that measured time to pregnancy in 500 couples. And what they found is that as sperm count increased from the so-called 15 million normal up to 46 million, the time to pregnancy shortened. Similarly, as motility increased from the 32%, which is the bare minimum, to 63%, time to pregnancy shortened. And the same true for morphology. So in other words, as the semen parameters improve towards the 20th, 30th, 50th percentile, fertility improves. And therefore, what is the clinical implication? If you look at the case to the left, here is a man with 10 million count, 30% motility. That's less than normal. You would label him as infertile. But The current thinking is that you don't look at semen analysis alone. You add to that the duration of infertility and the age of the male and the female. And if this is a young couple, wife is only 24, husband 25, they've been married 1 year, trying since 6 months. This semen parameter does not mean the male is infertile. There is at least a 30% chance that this couple will achieve a natural pregnancy. On the other hand, if you look to the right, 16 million, so it's above the minimum of normal, 40% motile, above the minimum normal. Even though you would call this normal, this is a couple where the wife is now crossing 30. They've been trying for 4 years. It is very likely that this semen sample is suboptimal, even though it is normal. And if this man has a varicocele, or if he's obese, or if he's a heavy smoker, I would want to correct these factors in the belief that I will improve his fertility and improve their chances of conception. So in summary, the 6th edition has thrown up many surprises. Morphology is perhaps its negative point. Discarding the reference range is a very strong positive point. And in the time that I have, I've thrown these thoughts to you because I think they are clinically very relevant. And maybe in future, we might discuss this in further. Once again, thank you very much for inviting me to be a part of this wonderful initiative.
Dr. Rupin, as always, pleasure to listen to you. And there's always that we learn something more each time I listen to you.
Thank
So
you.
you're as fascinating as ever. Thank you so much for being part of this ISAR Perfection series. And I can't thank you enough for holding the first ever masterclass during Dr. Duru's Shah's tenure and the second masterclass in our year. And I look forward to having many more masterclasses with you. Thank you.
Thank you for being so interested in male infertility, and we look forward to your talk.
Sir, sitting here in Bhopal, we keep getting files from you, from Leelavati with your paper. Patients are, you are the final stop for the patient as far as the third, fourth, fifth opinion is concerned. So they are convinced only once they show and consult Dr. Rupin Shah. Sir, so if I may be permitted to ask, what is your final message as far as sperm DNA fragmentation tests are concerned? Because now patients are Googling and they're wanting this test to be done. So we as clinicians, what is the message? Of course, we'll counsel them about the teratozoospermia. After listening to your lecture, we'll tell them to take it easy. But what about the DNA fragmentation, sir?
So even today, the AUA-ASRM joint guidelines do not recommend sperm DNA fragmentation as a first-line test, despite evidence that it may be playing an important role in reducing the chance of natural conception, reducing IUI success rate, being a cause of recurrent pregnancy loss, and impairing the outcomes, the early outcomes of ICSI. So if elevated sperm DNA fragmentation can cause all of this, why is it still not a first-line test? The reason is that none of the tests have been well standardized. If you have a patient and you send him to 2 different labs performing 2 different tests, he may come out abnormal in one lab, normal in the other. The cutoffs are not standardized. The cutoff that you would use for a tunnel test is very different from a cutoff that you would use from a halo test. So because there is inter-lab variation, inter-test variation, intra-individual variation, the test is not sturdy enough to be recommended as a first-line test, even though the physiological principle behind sperm DNA fragmentation is very solid. We hope in future, in fact, I have a slide in the talk which I didn't show you where they'd taken 50 men and subjected them to 6 different tests. And that slide is scary in the variation that you can see. But so for these reasons, we will advise sperm DNA fragmentation, but not as a very first test because it could mislead us. But if the normal semen parameters are normal and the couple is not conceiving, or the semen parameters are abnormal and the couple or the IVF specialist wants more information because 1 or 2 cycles of IVF have failed, or from a surgical point of view, if a man has a large varicocele, normal semen parameters. So therefore, you feel varicocele should not be operated. But if the sperm DNA fragmentation is high, then we would consider varicocele surgery. So in all these cases, we recommend sperm DNA fragmentation. The recommendation again from the guidelines is that whichever lab is doing sperm DNA fragmentation on a regular basis should try and set up their own standards, which means spend a little money on doing 40 or 50 normal patients to see what should be the normal for your lab, because there is a lab to lab variation.
Thank you. Thank you.
A very excellent, comprehensive, and lucid information provided to us about male infertility investigation. And it's really always mesmerizing listening to your talk.
Thank you.
Can we move on to the next session?
Yes, sir. Yes, sir. Sorry, sir. I had to take a call from Dr. Sunil Jindal. So thank you so much, Rupin, sir. And for
Thank
the
you.
session two, I invite my convener, Dr. Neelam. Neelam is there? Neelam, please unmute.
Was the elaborate lecture from Dr. Rupin Shah sir. We will take our pleasure to invite Dr. Amit Patki. Sir is President ISAR, Chairperson MSR. He is our nation's leader, and we always take great pleasure to interact with him. And we are looking forward to his talk on azoospermia. For his lecture, I will want to invite Dr. Meenu Agarwal, madam. And Dr. Meenu Agarwal, madam, is Vice President of Foxy 2026. She has held many posts, and she has been a course director for endoscopy and ART training courses. She has achieved many awards, and she is one of our very close gynecologist and leader from Pune. Our next chairperson is Dr. Ratna Agarwal, madam. She has also held many posts, and she has been chairman of Embryology ISA 2020 to 2022. She has been awarded Lifetime Achievement Award in Embryology, and also she's a very senior clinical embryologist. It is our pleasure to have you, madam, and I will hand over the session to you to introduce Dr. Falguni Bavishi, madam. We are very happy to have Dr. Falguni Bavishi, madam, here. She's a director of Bavishi Fertility Institute in Ahmedabad, and she has also a very leading name for best IVF chain in India West. She has first childbirth of India through the vitrified frozen oocytes. All three chairpersons, we are welcoming you and hand over to you to introduce our speaker for the day, Dr. Amit.
I would like to thank Dr. Monica and Dr. Randin Singh for inviting me for this wonderful webinar and congratulating them for this wonderful webinar. And it's my honor to chair the session. And Dr. Amit Patki doesn't require any introduction. He's the most vibrant and globally renowned fertility specialist. He's the medical director, Fertility Associates in Mumbai, consultant Khar, Hinduja and Surya Hospital, Mumbai, president of ISAR. He's the current president of ISAR, country representative Esquire 2021 to 2023, government council member ICOG 2012 to 2021, vice chair MSR 2023 to 25, chair West Zone RCOG 2015 to 2020, president Mumbai OBGYN Society 2014 to 15, and there he has many publications in national international journals and also 100 book chapters and editors of 3 books, 2 international parents. Two international patents in infertility and stem cell research, the direct speaker. So welcome, sir. And he's going to talk on the topic, azoospermia, what next? Welcome, sir.
Thank you very much. Can you allow me to share, please? Yeah. So At the onset, I would like to thank Dr. Monica and Randir. I hope you can see my first slide.
Yes,
Yes, sir. It's
sir.
visible, sir.
And also the vibrant trio of Manisha, Garima, and Neelam, who bring so much of vibrancy and joy whenever they are involved in any program. So thank you so much to the conveners and the indoor team. Monica, I must tell you that you are blessed not only to have Randir as your husband, but these three girls and your team in Bhopal. So I'm sure you must be having a very nice life because they are really, really very sincere. So thank you very much. And thank you for having this perfection series along with Isa. Today I will speak on azoospermia, and this is second thing that I often see people when they see a report which says absent sperm. The doctor and the patient both get panic, and often the patient is advised to go for donor sperm treatment. Now, that can be and may be one of the options, but I think we should look at how we evaluate and assess and what other options we can offer the patient. So when we talk of azoospermia, before we label somebody as azoospermia, I think it is extremely important that the sample is checked on two separate occasions, and not only look at the counts, but also make sure that the sample is centrifuged, and you try and look in the pellet, because almost 2% of patients you will find some sperms in the pellet, and that will completely change your diagnosis and the treatment that you would offer. Aspermia is absence of seminal material after ejaculation, and ejaculation is no ejaculation even after orgasm. And retrograde ejaculation is something where we would suspect if the volume is very, very low, and we would want to collect the sample from the bladder, from the urine, centrifuge, and check and see if we find some sperms there. Because if you do find sperms, it is very easy to alkalinize the urine a few days prior to collecting the sample. When you get a semen, two samples which say there is absence of semen of sperm even in the pellet, then it is important that you actually physically examine the person and also do a genital examination, scrotal examination, to check and see for presence of testes, to make sure that the testes are proper in the scrotal sac, to check and see what is the size of the testes, the turgidity of the testes, and whether you can feel the vas. You would want to do an hormonal assessment to check and see for the FSH, LH, total testosterone, TSH, prolactin, and I would also add estradiol, because quite often you would want to do the ratio between the total testosterone and estradiol, because that would help you to know whether you would want to add any hormonal treatment to this patient with clomiphene or with testosterone gels. If sometimes a patient comes to you with a testicular biopsy report, if the testicular biopsy has been already done, you can look at that report, because that will fairly tell you what is your chance of getting sperms, even if they say that there is no, that it shows a Sertoli cell, or it shows arrest of spermatogenesis. But if you are going to take a biopsy, if you take it for treatment, I would suggest you send a small part of that for histopathology, because again, 1% of patients with azoospermia could have carcinoma in situ. And I think they will not thank you enough if you pick this up, because this is something that can be totally missed in patients. There are basically and broadly two types of azoospermia. The obstructive azoospermia, which we see less common. Your semen report is suggestive when there is fructose absent, low semen volume because the maximum amount of volume is made from the seminal vesicles, and if there is obstruction, you could get a low semen volume. On examination, you'll find that there is normal testicular volume. You could have absent of vas very easily can be felt on examination. You will pick up seminal vesicle obstruction and ejaculatory duct obstruction only if you want to do a per rectal scan to check for the same. Now, when there is obstructive azoospermia, a urologist and andrologist would help you by removing the obstruction. However, in some cases, they would still prefer to go for the sperm retrieval and go and do ICSI. Whenever there is azoospermia, whether it is obstructive or non-obstructive, I think a genetic evaluation is very important. However, you look for different genetic abnormalities in the obstructive, which is basically delta 508, or in non-obstructive, you would want to do their karyotype and Y micro deletions. The technique of sperm retrieval is also different. In an obstructive case, you may want to do a PISA, and in a non-obstructive case, you may want to do a TISE or a micro TISE. Non-obstructive azoospermia is when your semen report shows presence of fructose, a normal semen volume because there is no obstruction. However, on examination, you'll find that the testes are small. They can be soft. You can have a flat epididymis. Your semen report can show an alkaline report. A hormonal test may show you an elevated FSH with normal or near normal testosterone and estradiol levels. And as I said, the way to obtain the sperms could be TISE, TISA, or micro TISE. In non-obstructive azoospermia, I think it is extremely important to counsel the patient in the first instance, risk of not finding sperms when you do the biopsy, and such couples should be counseled regarding the potential use of donor sperms if the sperms are not found in the testicular tissue. And although we hear of anecdotal cases of people saying in micro TC, I've always got sperms, or 90% of the times I've got sperms, believe me, it is not true. It is very important to understand and be realistic, even in micro TC, that your chance of getting sperm is not more than 30%. So you should counsel these couples of what they want to do, whether they want to abandon the treatment or whether they would prefer to go with the donor sample. If a histopathology, if a biopsy has been already done and you see what the dominant pattern is, if you find even one area of hypospermatogenesis in the diagnostic biopsy, I think your chance of getting sperm is almost 80%. With maturation arrest being the most advanced pattern in the sample, sperms are retrieved in 40% of cases. And even if the whole diagnostic biopsy shows you Sertoli cell patterns, you could obtain sperms in 20 to 25% of these patients. So it is extremely important that you take help of that histopathology. I don't advise you to do a diagnostic biopsy, but if it is done, you could have a look at that and then also probably counsel the patient on what are their chances of getting sperms from such men. In whom would you want to use the biopsy sperms rather than using sperms from the ejaculate? We find that testicular sperm retrieval in patients with cryptozoospermia who have had poor fertilization in their previous reports, poor embryo development, or poor blastulation and poor pregnancy results could perhaps benefit from samples obtained with biopsy. So you can have men with very, very severe OATs where there are very occasional sperms found. But in such men, you may want to go and do a biopsy if they have had a previous history of poor fertilization and poor ICSI outcomes. In men where you have done a sperm DNA fragmentation, and this understand can be done only in samples which have a count of more than 1 million, where you find that the persistently high sperm DNA fragmentation, then in such cases, in spite of giving them lifestyle changes, in spite of you treating them for their hypertension, diabetes, obesity, stop smoking, stop alcohol, take antioxidants, you find that the samples persistently have got high DNA fragmentation, then perhaps you could use the sample from the biopsy. In which cases would you want to do a scrotal Dopplers? I don't suggest scrotal Dopplers in each and every patient of male infertility. I think it confuses you more and picks up things that are not meant to be treated. I think scrotal Dopplers should be strongly considered in patients with cryptorchidism, prior sperm germ cell tumors, or in men who have got unexplained abnormalities on testicular examination. So it is very important that you cannot replace examination by doing a scrotal Doppler. You need to examine the men, and if you find that one of the testes is absent, you can't find the testes, you don't know whether it's inguinal, they give sometimes history of some testicular tumors and some surgeries done in adolescent, then I think it is extremely important to do a scrotal USG. Routine scrotal ultrasounds for subclinical varicocele is not recommended. I would do only if I can clinically feel the varicocele, because repair of such varicoceles which are found on scrotal ultrasounds has not shown to be effective in improving sperm parameters or even fertility. So once you have evaluated the person and asked for some blood test, you may come up with 3-4 options, and one of them could be very low LH and FSH, less than 1, which is called as hypogonadotrophic hypogonadism. And the differential diagnosis could be Kallmann's, morbid obesity, patients on steroids, pituitary tumors, or sometimes unexplained. The treatment modalities for men with hypo is a combination of HCG, 1500 IU given biweekly, with HMG, it has to be FSH and LH, 150 IU given intramuscularly, and the patient needs to be counseled. This needs to be given for a minimum of 3 months, even extending to 6 to 9 months. I've had a patient which I've jointly treated with Dr. Rupin, who was on testosterone injections because his gym trainer had advised him. It took almost 9 months for the effect of that testosterone injections to go off, and now we can barely see few sperms in his ejaculate. We have had men with hypo who needed to be treated for 6 to 9 months before you can get some sperms in the ejaculate. So it's extremely important to counsel, because this is going to be a rather expensive treatment, and the couple should be prepared for at least 6 months of treatment. You can have men with low testosterone, and if you have a low testosterone E2 ratios, these can be treated with anastrozole 1 milligram per day. For men who are diagnosed with Klinefelter syndrome, the response is better using testolactone 50 to 100 milligrams per day. Barring these patients with low testosterone and low testosterone E2 ratios, I think if you offer testosterone to these men, you will make their conditions worse off. If their prolactins are high and they come with erectile dysfunctions, we use the same treatment that we use in females with dopamine agonist. And if they have got adenomas which are large and giving them other problems like vision or headache, maybe surgery should be offered to them. But in most men with idiopathic oats, there is no evidence of effectiveness of treating with androgens, HMGs, HCGs, anti-estrogen, or prolactin inhibitors, or even steroids. And this should be you should strongly resist from giving these prescriptions. What happens if the LH and FSH is raised, particularly more than 15 or 20? You would call this as a hypergonadotrophic hypogonadism. Most common is testicular dysgenesis, Klinefelters, castrations, or if they've been exposed to cytotoxic medications or radiations for some cancers. Quite often, there is no treatment. You can offer hypergonadotrophic hypogonadism, and you may have to proceed ahead with treatments like ICSI. It was in 1992, we all know, that Palmer et al. Published the world's first baby conceived with ICSI. We all know by now it is highly effective therapeutic intervention in severe male factor infertility. And if you ask me, this is one test or one procedure which has truly revolutionized treatment in infertility practice, particularly in management of severe male factor infertility. But some of us may be aware that this was not something which was it was incidental, that some embryologist injected a sperm into the egg and found that that egg had fertilized. So we do not have any long records of phase 1, phase 2, phase 3 treatments. The treatment that has been offered is the log record that we have. And we know now that in certain cases of severe male factor infertility, there is concern of transmission of transgeneration and transmission of genetic defects to the offspring, causing gametogenic failure. As I said, ICSI bypasses the most effective biologic mechanism of sperm selection, which happens in IVF. Application to human reproduction, as I said, has not been preceded by extensive research trials, even in mammals. The human experience is the experimental record. And if ICSI is indiscriminately used, it can negatively impact the genetic composition of human populations for future generations. Hence, it is important in severe oats or in azoospermic men to do some genetic profiling before we counsel and start their treatment. 13% of azoospermic men can have karyotypic errors. 15% of azoospermic men can have presence of Y microdeletions. And in men, particularly less than 2 million, 5% of them could have karyotypic errors and 7% could have Y microdeletions. Now, what are the genetic abnormalities and the resultant reproductive abnormality that is found? If there is congenital absence of VAS, you must look for cystic fibrosis gene mutation. It is extremely important to check for that. And now in India, we get all the mutations that can be easily traced, because we know around 10-15 years back, Delta 508 was the most common mutation, but it was not common in the Indian population. It was common in the Caucasians. But now we get all the 812 mutation testing, and hence it is very important to rule out cystic fibrosis. When you have men with azoospermia or severe oligospermia, I think Y microdeletion and karyotyping is necessary to be done in such men. We also know that further meiotic disturbances, which are limited only to the spermatogenic cells, are found in 6% of males with severe oats. We also know that the origin of the sperm will make a large difference in miscarriage rates or major congenital malformations. Sperms which are used from the ejaculate, the first trimester loss is approximately 20 to 25%. When sperms are obtained from epididymal, the loss moves up to 30%. And when sperms are obtained from testes, the loss still goes ahead to almost 33 to 35%. And over the background risk of major congenital malformations, you have an additional 2.2% increase in the incidence of congenital malformations when you use testicular sperms. So the how and why of male infertility, as I said, almost 15% of men with azoospermia, 7% of male with severe oligospermia can have Y microdeletion. Now, what is this Y microdeletion? We know the Y chromosome is potentially inherited from the father to the son. We also know that Y chromosome is one of the smallest chromosomes in the humans. 98% of the Y chromosome is junk DNA, which means it has got repetitive codes, and it codes for nothing. Only 2% of the Y chromosome is what is actually codes for spermatogenesis. And that's why Y chromosome is actually a genetic junkyard, but also that 2% is the gold mine. Now, where is this Y microdeletion? It is on the 5th and 6th region of the Q arm, which is the lower arm of the Y chromosome. In that area is the AZFA, B, and C regions. You have other genes also which are present, which is the DFFR, the DAS, and the RBM genes, which are associated with male infertility. But whenever we talk of Y microdeletions, most labs would do the AZFA, B, and C, and some specialized labs now do the other 18 mutations. So, although I have compartmentalized this, when I say that when there is AZFA, it is lack of Sertoli cells, AZFB is spermatogenic arrest, and AZFC is maturation arrest of the post-meiotic germ cells. So 50% of males having deletions in the AZFC would have sperms present in the ejaculate. For men with deletions in the AZFB region, the chance of finding sperms is extremely low, and that is why it is important to know which area is deleted. The AZFC deletions are associated with Sertoli cell, in where almost 25% of them, if you do micro-TSA, you would be able to find the sperms. But it is not such a tight compartmentalization. Newer research shows that there is no tight correlation between the severity of the spermatogenic defect and the localization and the extent of the YQ deletions. And hence, it is very difficult to establish a good correlation between the genotype and the phenotype. Because there are other genes outside the AZF region, as I said, the DAS, the DFFR, which will add, and also some amount of environmental factors may modulate the effects of these deletions. But what is interesting is that these men in their very early ages would produce normal counts, and the expression or the expression of these genes happens particularly in the 3rd and the 4th decade of life. So if you know from before that this person has got Y microdeletion, you could want to freeze their sperms when they are in their teenage or in their early 20s, because at that time you would get normal counts. And this knowledge you can use if you have some male who comes with these Y chromosome deletions and would want to try using his sperms obtained from biopsy, because as we know, if he gets a male child, the child will definitely have Y microdeletion. But if you advise them to freeze his sample in his 20s and early 30s, maybe he would not have the problem of going through the azoospermia method. For patients where you want to do testing for the cystic fibrosis, the testing is done by a polymerase chain reaction, which is multiplex. Multiple columns are tested, and this would help us to manage the couple better. When counseling is done, most couples choose to have the Y microdeletion when it is offered, because they know it can be transmitted to the next generation. And not only Y microdeletion, the other karyotype is also important. We have started doing FISH directly on the sperms, and we find that a large number of these sperms can have diploid, where they have disomy of 18 chromosome, or a sperm can have X and Y. The sperm is supposed to be haploid, supposed to have the only one set of chromosomes, but quite often you find that these men can have, where there is severe OAT, not in azoospermic, but when you have these sperms obtained from OAT, you can have these abnormalities where the spermatocyte fish, which shows meiotic detects. Cystic fibrosis is an autosomal recessive disorder, mutations in the CFTR gene. You know that these men can have delayed puberty, are generally infertile, have azoospermia, and on examination, they have congenital bilateral absence of vas, which can be easily felt if you examine these men. Delta 508 is the one which is the most common deletion, which causes maturation arrest. The testing is by PCR testing. So ladies and gentlemen, in men with severe OATs and in men with azoospermia, genetic testing becomes an integral part of patient assessment and treatment planning. The package that can be offered is karyotyping, FISH on sperms, Y microdeletion, and cystic fibrosis if there is absence of VAS. Last two slides on azoospermia and testicular cancers. I often talk of male infertility being a window to a man's health, and that is where the sperm DNA fragmentation test comes into play. Because when you have an opportunity where you have a male infertility, I think it is important to look for metabolic disorders in these men, because quite often you may pick up hypertension, diabetes, thyroid issues. And in azoospermic men, you have a 1% chance of picking up carcinomas in situ. So if you collect any testicular tissue, you not only freeze it, but send a small amount for histopathology to rule out testicular malignancies. I think it is very important that you can look at these men and maybe offer them a better quality of life to the survivors. Often we forget these male infertility patients once a pregnancy is obtained. I think it is important to follow them up in cases of hypogonadism. Androgen replacement after completion of infertility treatment is extremely important. In patients with borderline testosterone and LH levels, you need to reassess them every 2 years. And when on sonographies, if you find that there is testicular microlithiasis, multiple calcifications in the testes, I think testicular biopsy should be considered at some point in time. Thank you very much for a patient hearing, and I'm happy to answer any questions.
I have
Thank you,
one
sir, for your
question.
excellent and elaborate talk.
Sorry.
And sir, one
Yeah.
question from me. Then up to what level of FSH one can get the sperm from the testes?
So generally in my clinic, once the FSH levels are more than 15, we tell them that the chances are low, but there is no cutoff level. I know patients who have had levels of 20, 25, and even 30 of FSH have managed. I'm sure Rupin must be seeing these cases often with high FSH, very small testes. The importance is that you do micro T, say you try your best, but I think they should be counseled and realistic counseling has to be done. Rupin, what do you have?
So the highest FSH in which we got sperm was 8080. I think from a practical perspective, the more the FSH, the more is the testicular damage. So if the testes are small and FSH is high, a simple needle sperm aspiration is unlikely to find sperm, and a micro TISA needs to be planned. If the FSH is normal, testicular size is reasonable, then you have an equivalent chance with a needle aspiration also. So for the IVF center personnel, experts who are listening, if it's high FSH, then you need to make sure that the patient is being treated at a center where micro TISA can be done.
I have one question, Dr. Patki. It was a very nice presentation as usual. What is your further take on the fish on the doing fish on the sperm? So if you find abnormal parameters in fish, so how do you go ahead in this kind of patients?
So it helps us to counsel such patients because now with availability of PGTA, I think such patients, I would put them if they've had recurrent implantation failures or they have had a recurrent pregnancy loss. If I find that the fish shows that the majority of sperms have got diploid or they have high incidence, because we test only for 5 chromosomes on fish presently. But if I find that they have a high incidence, then I would certainly offer them PGTA.
Yes, so that is what I'm coming to, that by finding this many abnormal sperm, then finally we may think of suggesting PGTA where we can take out those embryo which are abnormal.
Because I don't routinely do PGTA.
Yes.
My threshold is very, very high for PGTA. Even in patients who are over 37 or even in poor responders and such patients. I'm very, very selective on whom we offer PGTA. And in such patients, I would actually offer.
Dr. Amit, it was a fantastic presentation. Very nice. Always nice to listen to you. The flow is so beautiful from one slide to another. What I like, what is news, a new thing I learned is the relationship between a testicular cancer and the patients who have kind of oats or obstructive azoospermia, and you're doing a testicular biopsy. So, yeah.
Rupin, Dr. Rupin, would you like to add something? Because I think this awareness needs to be increased in the infertility specialist.
Thank you, Amit. First, I would like to echo the same words. It was an excellent talk, very comprehensive, very lucid. So I think it was absolutely perfect for the audience, and congratulations. About testicular cancer, it's both ways. The incidence in infertile men, as you said, is about 20 times higher. However, the overall incidence of testicular cancer is only 3 in 100,000. So even when it's 20 times higher, it's still 60 in 100,000 or 100 in 100,000, which is still only 1 in 1,000. So in both ways, we should not alarm patients that just because you have infertility, now you're going to get testicular cancer. But at the same time, before doing any TSA, we would do an ultrasound to look for an occult malignancy. And as you pointed out in your talk, the biopsy, which is sent to the pathology lab, needs to be examined for intratubular germ cell neoplasia, which is a precursor state for malignancy. So the incidence is higher, and therefore we should be alert, but not be alarmed.
Absolutely. I agree with you. But at the same time, I think the fertility doctors should be aware that this can be done. Quite often
Absolutely.
that sample is just thrown off. I think you can just send it for histopathology and
Absolutely.
then we can see what is it.
Yes,
So,
very
I had
nice.
a question. So I had a question. Sir, when you mentioned in your slides that in cases of first trimester losses, we are finding more of these percentage of losses as we progress from ejaculate sperm to epididymal to testicular. On the contrary, literature says that in cases of RPL and first trimester pregnancy losses, we can have testicular sperm as one of the measures which can prevent the losses. So, what do we do?
I still stand by what my slide says, that the incidence of miscarriages and major congenital malformations are in a way related to male factor, to severe male factor infertility. And this is something that we have to counsel them. We often thought it was a procedure of ICSI, but it is not the procedure of ICSI. It is the sperm that is obtained is because previously when this paper was done, maybe there was no karyotyping done and you would pick up these patients. But I think it is important that you tell them that the incidence of miscarriage can be high depending on the origin of the sperm. My second concern for using TISA samples is we do not know what are the epigenetic changes that may be happening in these children. You get a pregnancy, you get a child, but we do not know what are the epigenetic changes because we are taking sperms which are from the testes and not the sperms which have gone through the full maturation process. So I think we have to be very careful. The reason for saying this is because quite often people indiscriminately use testicular samples when the ejaculate sample sperms are there. I would use it only in cases if we have found that the DNA fragmentation is persistently high. People don't wait to treat men. They just straight away go and say, okay, we'll use TISA. We have to give it a chance. We have to wait for a few years. Maybe we will get some epigenetic reports coming up from such men. So we have to be aware.
Thank you. Thank you, sir, for clearing
Yes,
that.
yes, Amit sir, I totally agree with you because this is very, people are very in hurry doing the TSA and dating testicular sperms. And the second part about the neoplasm, sir, I am getting at now 14-year-old child with the neoplasm. And Rupin sir, 14 year, though it was difficult, but he masturbated and gave me a very good count of 70-80 million. I have preserved that sample. So, Amit Patki sir and Rupin sir, I've stored those sperm, and after 10 years, he survives and get the marriage. The epigenetics does have a role on these cryopreserved sperms also of the maintenance patients.
Yes. Yes.
Okay. Thank you, sir. Very nice and to the point. As I initiated in my talk, that it touches your heart. Nanita madam also told male factor means Rupin Shah sir, who is the, I think, not a national but international authority. When we started practice 25 years back, he was a person, patient used to fly from Bhopal to Lilavati, Rupin Shah, and that thing. Yeah, Dr. Monica, you can continue.
So
Thank you.
it's the best combination of speakers we could have got. Absolutely the best. Even if we think for days, we'll not get a combination which is better than Dr. Rupin Shah and Dr. Amit Patki. So thankful for your presence, sirs.
Thank you so much.
Thank you so
Thank
much.
you.
So
Really.
I thank you, thank all faculties, all chairs for this session and as well as session 1. And now I request Garima and Neelam to please start the panel discussion.
Thank you, Monica. Thank you, everyone.
Thank you, Meenu ma'am. Thank you for joining. Thank you.
Thank you.
Thank you, Amit sir, and thank you, Rupin Shah sir. And now from basics to azoospermia, we come to a very interesting panel discussion on dilemmas in treating male factor infertility on day-to-day basis. And we have our pioneer in this field, Dr. Sunil Jindal, with us today, who's going to moderate this panel with, again, a very august panelists. And Dr. Jindal is a consultant andrologist and scientific director at Jindal Hospital and Fertility Center. He's a founder of Freedom from Infertility Society. He has been the gold medal for postgraduate at MAMC New Delhi and 35 awards from different organizations. He's also known to be one very influential YouTuber and has received the very prestigious Golden Play Button awarded YouTuber for more than 2 million followers, and he has almost 300 million views across all the platforms. And he has several publications to his credit with special interest in fertility enhancing endolaparoscopic and microscopic andrology surgery, sexual medicine, and special interests in surgical, medical, and laboratory andrology. I welcome you, sir. And we have our expert with us today, Dr. Dipankar Banerjee, who's the consultant reproductive medicine at Ideal Fertility and Genetics Center at Jabalpur. So Dr. Dipankar Banerjee has been practicing OBGY with special interest in reproductive endocrinology and fertility medicine, and working also in the area of interventional sonography, endoscopy, and IVF and prenatal diagnosis. I welcome you, sir. Over to you, Dr. Neelam.
So I will take a pleasure in inviting all our panelists. Welcome to all our panelists. Please, let's see our first CV. Our panelists for the session are Dr. Akanksha Mishra. She's a clinical embryologist. She's been working in embryology field since 2003, and she has held various positions. Right now, she's director of and chief embryologist at Janani IVF in Delhi. Our next panelist is Ms. Atita Shinde. She is chief embryologist at LH Hiranandani, and she is also holding many positions, and she is also freelancing embryologist. Welcome, Atita.
Dr. Indu Chauhan. She's the consultant gynecologist and endoscopic surgeon and ART specialist at Vardhan Maternity and Nursing Home and Vardhan IVF Center at Jamshedpur. And she has been the past president of the Jamshedpur OBGY Society. Can we have the next CV, please? Dr. Kanav Jain, who's the embryologist at Jain Fertility and Mother Care Hospital, and he has done his master's in clinical embryology from Monash University. Dr. Keshav Pai, he's the chief endoscopic surgeon at Silver Lining IVF and Endoscopy Center and Dharmadhikari Hospital in Pune. Neelam.
Dr. Mrinmay Dharmadhikari. She's also co-founder and co-director of Dharmadhikari Silver Lining from Pune. Welcome, Dr. Mrinmay.
Dr. Poonam Raikwad, she is the director of Pranshu Hospital and Laparoscopic Center in Indore with 12 years of experience in the field of endoscopic surgery.
Dr. Rajendra Chitole, he is clinical and academic head at PG Guide, and he is working as a consultant at DY Patil Hospital and Research Center in Pune.
Dr. Rutwij Dalal, who is the IVF specialist and head at Janani IVF New Delhi. He has 11 international publications and 23 national and has received the Isar Manish Pankar Young Achievers Award in 2019.
And our Dr. Sachin Dalal. Welcome, Dr. Sachin Dalal. He's very renowned. He's very active in academics and teachings. He's director of Madhu Hospital in Bhandup and Embryo and IVF in Vikhroli. He's also attached at Fortis Jupiter and Surya Hospital in Mumbai. We welcome you.
Dr. Shashikant. Okay, go ahead, please.
Dr. Shashikant Umbardan, he is also very senior practicing consultant in field of fertility. He's the director and consultant of Mangala Nursing Home and Atharva Fertility in Solapur. He is very prominent in Solapur, and he has held MSR post from 16 to 20. He has been executive member. We welcome Dr. Shashikant.
Dr. Suyesha, a very, very close friend from Delhi. She's an IVF expert, obstetrician, gynecologist, and cosmetic gynecologist at Angel's Hope Hospital, New Delhi, and also an IVF expert with the Bloom IVF. And she has several accolades to her credit, with her field of interest in being in infertility, laparoscopy, hysteroscopy, high-risk obstetrics, and cosmetic gynecology. I welcome you, Suresha. And with this, we hand over the stage to Dr. Sunil Jindal and Dr. Dipankar Banerjee. So you are on mute, sir.
Sunil sir, please unmute.
Yeah. I'm unmuted now. I'm sure you can hear me, and thank you very much for inviting me to this lovely panel. Thank you, Dr. Monica, for inviting me. Thank you, Dr. Garima, for organizing it so well. And thank you all the panelists whom I have, a lot of whom are friends with me, and an expert like Dr. P. Dipankar Banerjee, of course, who is a fellow YouTuber and was a YouTuber much before me. So it's been a pleasure being here. Now, very importantly, I've tried to create a panel which I've never done before. I've never done this panel before, I mean this writing before. I've organized it into 15 cases, one question, and I would request from all the panel to actually do two things first. Please put yourself into side-by-side gallery. Side-by-side gallery. If you go up into the view section, you're going to go into a view section which is going to be side-by-side gallery. That will help us that anybody who's seeing us will be able to see all of us along with the slide. So anybody who's answering could be seen together. So that will be the best thing and the first thing to do. The second important thing is, I have with me Dr. Akanksha. I don't know who are the people out of the people who are there on the flyer who are missing out. If I could know, I just strike out their name before answering or asking them a question. And the third important thing is I would really like you to be short, brief, so that any question and any case could go around to most of the people who would like to answer. So we all know that male fertility is the most neglected thing. Man, as it is not taken care of by either advertisements or I would say news, or I would say even the eyes of human beings. Forget about the gynecologist looking at you. So these poor males need attention in your fertility clinic because 50% is the contribution of the man. And there are a lot of challenges, a lot of things. The panel is key questions, and in the end, I'm putting down the guidelines which are there for all of us. So let me just move on to the panel straight away.
Sir, one panelist is missing, Dr. Indu Chauhan.
Dr. Indu Chauhan, thank you very much. So just a minute. So just put in side by side, put in so that all of us could be seen. And I can see Dr. Banerjee is in his long clinic, and I can see everybody over here. So I'll begin with the first slide. And the panel discussion is about a case of oligospermia. Most commonly seen case, 30-year-old couple, married for 2 years, trying for conception. Wife has everything normal, menses, ultrasound, bilateral tubes, and even the AMH. Husband is healthy, non-smoker, non-alcoholic, no history of any orchitis. Now, I'll come to the investigations. By WHO 6th edition protocol, 2.5 ml, 10 million per ml count, 40% motility, and a morphology of 5% by strict criteria. Now, my question from everything is a very simple thing. Now, what should be the first line management? Investigation, if any, lifestyle modification, antioxidant, or an ART right away? I'd like to ask this question from anybody who's a clinician. What is exactly
Can I ask?
Yes, of course,
Can
Dr.
I go
Sachin.
in?
Yes, Dr. Sachin.
Hi, sir. Good evening. Thanks for this question. So, she's only married since 2 years. Young girl. Everything is okay. Just mild male factor infertility. Maybe lifestyle modifications and a good course of antioxidants. Uh, Cold scrotal wash, loose underwear, drink plenty of water, one fruit a day, which is missing from a lot of people. And regular sexual intercourse, I think, should get them on track for a pregnancy.
Yeah, I honestly feel it's a fantastic answer which you have given. Anybody else who'd like to join in something?
Sir, I'd like to first repeat the semen count once. just to ensure that the count is right the first time, and also take a detailed history with respect to his lifestyle. And then, as Sachin sir had elaborated, we can go ahead with the treatment accordingly.
Great. Any other person who'd like to add anything to it?
So, sir, my plan would be like the lifestyle modification for the modifiable factors like smoking, alcohol, weight reduction, and everything, with the proven antioxidants which have in the literature like CoQ, vitamin C, vitamin E, followed by 1 or 2 IUI cycles. If necessary, repeat semen analysis has no improvements, and total mortal sperm count is improved. And then, if everything fails, then we will go for the IVF for the XA. So that would be the plan, maybe device for him.
So I just have something taken out from the AUA ASRM guidelines and for the literature of WHO manual. Repeat semen analysis at least, and this should be done on 2 samples with proper abstinence. First thing. Oligospermia is not equal to infertility. Many men with counts up to 10 million can actually have a natural conception if the motility, morphology is fine and the quality of the sperm is good functionally. Offer some basic investigations if needed. If the person has anything like pain earlier, UTIs earlier, a culture or something. As everybody has pointed out in my August panelists, that lifestyle modification, empiric antioxidants, that again is a plus minus, and ART is not the first line. This is something very clear. Dr. Banerjee, anything you'd like to add to it?
Sunil, good evening.
Good evening. Good evening.
It is a very complex situation, and this is the very commonest situation what we day to day we have this type of affair. And whatever has been done and told by the panelists is absolutely correct. We should wait, and definitely what you have said that these things, even the lesser number of the sperms can create a natural pregnancy. I absolutely go with the panelist and wait. But there is, if it is not possible that she is not getting pregnant naturally with this type of affair, recently I read that like Poseidon criteria, there is an Aphrodite criteria nowadays.
Yes.
These type of scenarios, Dr. Sandro from, I think from Sweden,
Sandro is from Brazil.
Brazil.
Yeah.
He has developed a Aphrodite classification like Poseidon classification for male infertility in the same way. And he has separated 5 classes, and this type of affair, he proposed that if it is not possible that she is not getting pregnant even after repeated whatever the non-ART methods you are using, as we use gonadotropins in female to induce ovulation induction, in the same way, he has a proposal that you can start this fertilized cell stimulation by creating more spermatogenesis. I don't know how far it is
No, sir,
possible.
that Aphrodite criteria and that whole classification is something which has not been fully accepted till now.
Yes.
So I particularly just wanted to place in all those things,
Yes.
though what you're saying is correct, place in just all those things which actually could confirm with the guidelines which already have been given.
Yes.
So that is what I actually thought. And thank you very much. And I'll move on to the next case, which is azoospermia, which comes to every case. And it's a very similar case, just like the previous one, which comes to every clinic. 28-year-old, married for 2 years, no pregnancy, no history of mumps, undescended testes, any exposure, normal libido, erection, everything. Wife is 27, young with normal investigations. Now, 2 semen analyses have been done, azoospermic, volume 3 ml, alkaline. Testicular examinations, testicle is small, about 10 ml, firm, bilateral vas deferens is palpable. Serum FSH is 18 and the testosterone is 4.2. Now, the question I want to ask you is, in a patient like this, who you have with you with a small testes, but a normal testosterone, how will you think you'd be able to differentiate between obstructive and non-obstructive azoospermia? And when is the time that you need to refer this person to a urologist or an andrologist?
I'll take this question. I'm Dr. Swesha. So when we talk about obstructive and non-obstructive, we basically examine the patient by seeing the size of the testes, the testicular volume, the FSH, LH, the semen volume, pH, and fructose. And when you're given this case and you want to differentiate between obstructive and non-obstructive, we need to check it for the pH and fructose level. So if the fructose is absent, it's a case of obstructive azoospermia. And if it is normal, so it's a case of non-obstructive azoospermia.
So Yash, I'll just like to place something in front of you that the absence of fructose does not make it an obstructive azoospermia. The absence of fructose only tells us that the obstruction is at the level where we are not able to get anything from the seminal vesicles. So if the obstruction is at the level of the vas or the epididymis, fructose will be available in the semen sample. So so just understanding one thing very simple, that obstructive azoospermia is when the testes is making sperms, but obstruction could be at the level of the epididymis, it could be at the level of the vas, it could be at the level of the seminal vesicle, prostate, or the ejaculatory duct. Now, if it is there at the ejaculatory duct, then fructose won't be there and it's going to be a low volume. But
Yes.
in case the obstruction is down the line, you're going to have a good semen sample, adequate semen. It's not a low semen count. You don't need to do an ultrasound for a truss. And this is the patient who would be judged as an obstructive azoospermia based on, number one, the testicular volume, FSH. You've got to palpate the vas. And if there is a small, firm testes, this testes is small, and elevated FSH, you probably could have a non-obstructive azoospermia. Now, I'd like to ask all my panelists over here, which is the patient for whom you would like to get a transrectal ultrasound done?
It is for the when we suspect the ejaculatory duct obstruction, then we usually prefer to do the truss.
Right. So when will you suspect an ejaculatory duct obstruction?
When the fructose is negative in the sample,
Low
low
volume
fructose in the
pH,
sample.
acidic pH,
Now,
low volume ejaculate, acidic pH, and basically there is a distension of seminal vesicles that is more than 1.5 centimeters into anterior posterior diameter. That's when we do a truce to rule out ejaculatory
perfect. Perfect. So if you see this patient, he has a normal volume, he has an alkaline pH, and along with that, this person also has small testes. So this is a patient who
Looks
probably
like
would.
testicular cause.
It could be, yeah, it could
Yeah,
be a
testicular.
yeah, it could be a
No problem,
non-obstructive
teacher.
azoospermia. So I'm going to just ask all my panelists, including the embryologists, because the embryologists have a very major role at times in the whole center. In fact, they at times, I would say, are people who work very hard, and they are the people who contribute a lot. So I would like to ask everybody, when is it that you would decide that you would want to refer this patient? I'm asking you this question from the point of view of me seeing so many patients every day. Rutvich, could you please on your camera, please? I'd like to see you on camera. Fantastic, fantastic. Thank you very much. So I would like to ask you, when would you refer a patient of azoospermia to a place where they could be doing work as a micro TSA or any other work for that matter?
So the
Anybody?
lab has to be, the OT has to be equipped with all the necessary equipments. The embryologist needs to be experienced in micro TC procedures. She or he needs to be patient in hunting for the sperms. The surgery might go on for 2 hours, 3 hours. We have to keep on going on, trying to hunt for that coveted sperm that we find, which can, fertilize a single oocyte. And it's a laborious procedure, it's a tedious procedure, but then we need an experienced embryologist.
See, I'll tell you what, I'll tell you from my experience, what you're saying is perfect, first of all. What you need is an experienced surgeon, number one.
The flow and who
Number
agrees
two,
to.
number two, you need a theater. Number three, you need, of course, his whole team working. And you need somebody who really loves doing this work to be able to give an azoospermic a baby. I tell you why. Um, a lot of you must have experienced it too because you do so much of work. I get so many patients of non-obstructive azoospermia who have had a needle aspiration of the testes and they have been told that there is no sperm and a donor sperm is used. Now, the truth remains, uh, these are the patients who need a referral only for the reason that probably a lot of these people could actually have their own sperm. But a needle has been used in non-obstructive azoospermia and they have been told they are no sperm. So I think my personal feeling is for everybody who's doing ART, and I say it with a well-meaning idea for the patient, that any patient where you feel there is non-obstructive azoospermia, obstructive azoospermia, do a PISA. Everybody can do a PISA. You could do a MISA, not a problem. For a non-obstructive azoospermia, instead of doing a needle aspiration and saying that the work has been done, it is better that the patient is referred to a place where this work could be done.
Agreed.
Rutvij, you agree with me?
Absolutely.
Right. So this is the slide where the message, because there would be a lot of people listening, and if they give me the film, if they give me the film now, I actually am going to put it up as an optimized view for a lovely panel discussion with the most elaborate speakers whom I ever could get on my channel. And this would be probably viewed by a couple of thousand people in the next week itself. So therefore, I particularly feel this was a message which I really wanted to give from across all of us as the panelists. This is a beautiful slide again of asthenozoospermia, uh, where somebody would you try to jump onto IUI or IVF? I'm going to ask this in the end as an expert from Dr. Banerjee as well. So there is a 29-year-old woman AMH
Sunil,
treatment.
can I interrupt? Can I
Of course.
interrupt a little bit?
No, you can
Sunil,
interject. No problem.
I agree with Rituj that what is your average time to search a sperm with the microthesis?
Can I have your video, please, sir? Yes, please.
I'm just asking a question because this is a very important question from Rituj that what is your a microthesis? Definitely, we have to refer this patient with non-obstructive azoospermia to the specialist who are doing microTC samples. But what is, I know you are doing that, but what is the normal timing for the embryologist for finding a sperm? Do you do microTC sperm retrieval first, then oocyte pickup? Third, do you always do Y chromosome microdeletion for these patients?
I think this is a fantastic question. Now, in the last, I've been doing micro TCA for the last 8-9 years now. And thanks to the YouTube and thanks to people referring to me, it's a large number which I do every month. And I have tried to optimize the procedure completely, which I'm going to speak in embryology ISAR, from the optimization in the theta to the optimization in the collection in the theta to the optimization of carrying that specimen, finding the sperm in the lab, which with method, and then further on the ICSI. So I'm going to present that whole half an hour talk in ISAR. But in a nutshell, number one, you've got to get a Y chromosome microdeletion 100% mandatory with karyotyping done before you plan a micro TCA.
Yes.
Number two, you need to have all the parameters with you, including the FSH, LH, testicular size. You should, in all these patients, have every parameter with you. Number four, I always do an ultrasound of these patients.
Yes.
Now, it's a very, very funny thing because I have my own ultrasound and I do for all these patients. There is a judgment which I have made, a very categorical judgment which I have made of the vascularity and where the testis
Yes.
is.
Do you do Doppler also?
I do a Doppler too, exactly
Yes.
for vascular.
Yes.
Right? Now, the next important thing is the counseling. Now, counseling is most important. You have to give the patient a clear idea. Now, the patient has small testes, a very high FSH.
What is your lowest limit, Sunil?
The FSH level, I
No,
have
what is the lowest limit of testicular volume?
the lowest limit is about 6 ml.
Okay, very nice. Okay.
So, and my FSH till now has been 72, where I have retrieved
Very
72.
nice.
So
Congratulations.
now I'll just share with you what all. I'll just share it over here because I have this August gathering over here. Dr. Dipankar is there. And now what I normally would do with these patients is I would counsel them. In the counseling, I'm going to definitely tell them 4 things. First thing I'm going to tell them is that the chances of retrieval of a sperm are X. If I feel there is a Sertoli only, I always tell them about 20%, nothing more than 20% ever. I would tell any maturation arrest whom I find about 30 to 40%. And if I feel that probably there's hypospermatogenesis, still I would only tell them about 50%, not more than that. Now, the reason for this is very simple, that the patient needs to be made prepared for the fact that his sperm may not be retrieved. And his wife also should be comfortable with it. The second thing which I normally do is I'm sharing everything the way I do it. The second thing which I normally do is I share this with when the wife is sitting in front. Now, what happens when the wife is in front of you with the husband? The fact that the woman is understood this clearly that the husband is azoospermic, and in case a sperm is not got, will they be ready for a donor sperm? I always do a fresh ICSI, micro TC, with the ovum pickup for every non-obstructive azoospermia, because I personally have the greatest, I would say, liberty of having a theater as well as a lab together where I could operate. You'll be surprised to know when I went to Cleveland Clinic long time back, they cannot, because they just don't get the theater time to ever do live. And I came to know in the United States, very few centers are such that they could do simultaneously micro TC as well as I would say an ICSI.
ICSI,
So,
yes.
so most of them actually do a micro TC, freeze these sperms, and then do ICSI after that. But at times you get such few sperms of such low quality that you need to be fresh in terms. Two. Number three, I always ask them that will you be ready to get a donor sperm done in case sperms are not found? Now, if they say no, then I never and we never do a pickup of the woman. We would give them the option that we probably would do a micro TC. If we get sperms, we freeze. But if we get sperms which are very less in number and we need to do a micro TC again, you should be prepared for it in case we get them for the next issue, in case the sperm we got are
Sunil,
less.
this is what you are telling. This is the most of the commonest thing we do in our ART practice. I think all panelists do this before doing this. All consents has been taken before doing all these things. But there are multiple questions. But I am not putting all these things because this is the practical things what we are facing in day-to-day practice. It is
Now the time.
very difficult to freeze even the TISA samples also.
Correct.
And even for the freezing the micro TC sample, it is very difficult to retrieve the sample later on. And the problem with this is that if I do TISA, I don't do micro TC. If I do TISA, even with the TISA, the sample I am sending to my embryologist, she's my wife, she is looking after the problem that if I do, should I do the TC first and then ovum pickup? If there is no TC, no sperm, then should we defer the ovum pickup if they don't want uh, donor sperm? Then all the ovum stimulation and all everything has been gone waste. The problem is that if we search the sperm in the TC sample, it takes sometimes a longer time to find a single sperm in the whole lot, especially if it is blood mixed. But as we practice, the mixture of blood is less. But the problem is that if we do pick up and we wait for the TISA ICSI to be done, then there will be time to the oocyte to get mature because we do some maturation of 2 to 3 hours or 1 hour, depends upon the HCG timing. This is the problem. I think if you can share that
Yeah, I
in
will.
your
I will. I will. We normally do a micro TC before we do an ovum pickup. The reason is simple. A lot of times, if we are not able to find a sperm, we actually incubate the tissue and we go in ahead again. So, in case we get sperms, fine. And the pickup we normally do after we have done the micro TC. First thing. The second important thing is the time which you asked me, how much do I take? There used to be a time when I used to take about, it depended on the patient. It could take 1 hour, it could take half an hour, or it could take 2.5 hours at times. I have two embryologists working simultaneously on the table, and the specimen goes to them, and every specimen, it's a very interesting thing. WhatsApp video call is amazing to have. That's the only thing which you need to hook onto your, I'll just show everything onto your lamp, I mean the OT light. So what happens is, from the OT light itself, they are working over there, you would know whether it has been found or not. But now lately, for the last 2 years, the time which normally I take is about 35 to 45 minutes. And the reason is very simple. Your eye gets trained onto tubules which you think you could find.
Fine.
And I mean, it's a practice. It's just
Okay,
practice.
Sunil, I think it will be a long discussion between you
Yes,
and me.
I
It is
think,
better to go
yeah,
for the
I
panel
think
to
so.
go with.
Now the question is from all of us, that you have this patient who has 15 million count, 18% motility, and 6% morphology. Something which I'd like to ask is, there's no varicocele, hormonal profile is normal. Should such couples attempt IUI or go for IVF ICSI directly?
Good evening, sir. I will take this question.
Of course, sir. Madam.
Myself, Dr. Poonam Raikwar from Indore.
Right.
This is the case of azoospermia. It is a very common in the infertile men. 20% of infertile men have a azoospermia. So the role of IUI is very valuable in these cases. But the condition is, if the total motile count is more than 5 million, then we can go for IUI. Or post wash sperm count is more than 1 million. So there is a role of IUI in these cases.
Okay, great. So I'd like to ask the second question, that how many IUIs would you like to do for a 29-year-old lady who has an AMH of 3.5 and with the semen count like this? And after how many IUIs would you feel, and in what condition would you feel that IVF or ICSI would be a better chance for patients?
So talking about number of IUIs, 3 cycles of IU are more than enough, because there have been studies that if you go beyond 3 cycles, the result doesn't really change. So I would offer 3 cycles of IUI to this patient.
With the IUI, I also add on the lifestyle modification, add of antioxidants, so that the chances of IUI is better. And after 3 cycle, go for IVF.
I think it's a fantastically answered
Sir,
question.
I'd like to add one thing.
Right.
Sir, this is Shashikan from Sholapur, sir.
Yes, please.
What we need to see first is that what we get at the post-wash sample. What is the total motile count in the post-wash sample? Because this is the count what we are getting over here. In the first or second IVF, we may be able to know how much we are getting in the post-wash. And if the post-wash is less than 5, it is useless to continue with the IVF for this patient, because this is going to give them less than 5% chance of the conception.
Yes, so if you cannot transfer more than 1 million motile sperms within about 300 microliters, in that condition, there is no point of doing an IUI. Now, I'd like to ask another question over here from everybody. Do you normally do all your, would you consider these IUIs Letrose IUIs or gonadotrophin IUIs?
So starting with letrose or IUI and then moving on to gonadotrophin IUI.
The patient has already come to you after taking 5 cycles of IUI, of letrose. That's the way everybody comes to you.
Then we have to go
Then
ahead
we
with
go for gonadotrophin IUIs.
What would be your success which you think of a letrose IUI cycle and a gonadotrophin IUI cycle?
So the gonadotrophin IUI cycle result would be roughly around 30 to 33%.
Any IUI cycle across the world
will not give you more than 25%.
20%.
So 10 to 20%
But with gonadotrophin IUIs, the results are better as compared to oral.
It's about 5 to 10% more than letrozole.
Yes,
exactly.
Sir, only
because
difference
18 to 20%, you can quote
multipolymer.
25% for a gonadotrophin IUI.
Actually, literature says, I'm talking of large studies, about 12 to 16% result from a gonadotrophin cycle.
Yes.
And
And
literature 33%.
9 to 12% for
yeah,
the lateral side.
yes, so actually the most important thing is counseling the patient again. See, why does the patient stay with you? Just understand. I'm saying this, Dr. Dipankar would add to it. A patient stays to you because the patient says that uh, whatever he's saying is correct, because everybody nowadays checks everything you're saying. And they don't check on Google on the IVF sites of doctors. They check it through literature, especially with Perplexity being there and ChatGPT being there. So you've got to be very, very clear that you've got to talk to the patient the data which is there in literature. Because if he sees that you're speaking more than what the literature is, he understands that this is probably the place where I may get pregnant, but it is incorrect what I have heard. So this is something which I always would feel should be there. So, Dr. Dipankar, you'd like to add something to it?
I mean, that is after 2 to 3 cycles of gonadotropin IUI, you can quote the result is up to 30%.
Yeah, you could say that for sure. So let's go.
Cumulative rate I was talking about.
Okay, great. So we go on to the fourth case of the lifestyle factor. So a 35-year-old IT professional, um, people in Bangalore, Gurgaon get a lot of IT professionals. They're absolutely a different class of stressful people who actually don't take care too much of themselves. So BMI 31, sedentary, smoking 10 cigarettes a day, drinks 3 to 4 times a week, high work stress, married for 3 years. Semen is borderline, count about 15 million, motility 35%, morphology 3%. Now, how much role does a lifestyle correction really play in improving male fertility?
In such a
Can I take it?
patient, I think lifestyle correction is the way to go, because it's not only he has all the factors that are contributing to infertility, like stress, smoking, drinking, everything. I'm sure if you check the DNA fragmentation of this patient, it's going to come out high. There are more chances of it being high than normal. Also, we need to take a little bit of personal history, because many a times people who are in this stressful job situation, they don't find time for each other. So instead of jumping to treatment, I would suggest lifestyle modifications, some antioxidants probably to undo the damage that has already been done, and suggest them to take a vacation, maybe to spend some quality time together.
I think it's very important lifestyle for all of us. In fact, anything which is good for the sperm is also good for aging. So, how many of you take vitamin C and vitamin E daily?
C.
Vit-
Vitamin C, sir.
Vitamin C and E daily. The reason is very simple. It's anti-aging. One is a water-soluble vitamin, and the other is I would say, lipid soluble. So it's very important for all of us to take this from the point of view of not our sperm probably at this time, but probably also the aging process. And lifestyle is very important. What is it? I'd like to ask each one of you, uh, what is it that you actually suggest to your patient in terms of not what you say, or what is the method by which you give everything to these patients?
First of all, start with nutrition.
No,
In
how do you suggest? See, I'll give you an idea of it. Why I say this is because I actually would like to speak to everybody. See, what happens is you cannot talk to your patient because time is the essence of everything for a very long time. So, in any clinic which is rushed up, to tell them this, either you need a counselor who could tell them this, or you could give them a handout or an ebook who could do it this. But the best actually is to,
Just
after reading
them
literature,
yourself.
give them a video. I mean, they would feel they are with you. So giving a video is very useful. In fact, it is the most useful thing to do. And if you give this to optimize to every patient of fertility, male and female, who walks into your clinic, not from the point of view of IVF or ICSI or IUI only, every patient preconception who wants a child, I think that would be wonderful. Dr. Dipankar, what would you say to it? Dr. Dipankar?
I think Dr. Dipankar.
He sent a message that he has to go.
He
Okay.
has to go.
Yeah, he had to leave.
Okay. So now it's a fifth case, which is a post-mump orchitis patient, 36-year-old with history of bilateral mumps orchitis for 12 years, married for 2 years, no comorbidity. Investigation. Now, please, he's a 12-year-old child. Now, semen count is 3 million per ml, motility is 25%, FSH is elevated, testes and small and firm. Now, the question I want to ask you is, should these patients be counseled for sperm freezing or donor sperm?
Yes.
Why donor sperm
Not
in
for
this case?
donor sperm straight
No,
away.
I'm asking,
Sperm, sperm
I'm asking,
freezing.
I'm
Sperm
What
asking
is
freezing
you a
for
what
sure.
question.
is sperm freezing?
Sperm freezing.
Sperm
Sperm
freezing.
freezing.
Sperm freezing.
Right,
Sperm
right.
freezing.
Now, if you do sperm freezing for these boys, he is a 12-year-old boy. Now, just it's a very important question I'm asking you because I get these children. And also people who get cancer. It's not only mums, it is some child who's got cancer needs chemotherapy. What is the history which you're going to ask these adolescents? You're going to ask them
Whether
if
it
they
is
can
History of
masturbate.
fever, history of inflammation in the testis.
No. You're going to ask them the history
Masturbation.
of, can they masturbate? Have they masturbated?
okay.
Do they discharge semen? Have they undergone puberty?
Okay.
It's a boy, 12-year-old. It's not necessary he's had puberty. So this is a very important question which you probably may need to ask the child. Now, mump orchitis can at times give permanent damage. Cryopreservation needs to be done. But at times, these children are not able to give you a sample. Now, they have never masturbated, they have not attained puberty. What is it exactly? Now, isko to hai because iska to semen sample hame mil gaya hai. That's
Yes.
why we know the semen count.
Yeah.
But if there is any other child who has never masturbated and has not undergone puberty, what will you do?
Vibro ejaculation or electroejaculation.
Not really. Because if he's not undergone puberty, it is not necessary we're going to get anything. And electroejaculation is a
Hormonal evaluation will
Can,
be the first step to
can
go
can
ahead.
I take that? Sunil sir, can I take that?
yes, please.
Yeah. So since he's 12 only, he's not yet attained adulthood. His parents' consent is mandatory. They should be a part of the decision-making process. That is one. Secondly, we just had a panel on this similar case at ISAR Masterclass last weekend at Hyderabad, where there were 2 or 3 options that came up. One was, as Rutvij rightly said, is try for vibrators and at the base of the penis, and the chap might be able to ejaculate. Two, do a TISA for him and preserve the tubule.
Now, if you preserve the tubule of a place where spermatogenesis has not taken place, what is exactly that you would feel you would like to do with that sample?
No, sir, my answer would be we should go ahead with the hormonal evaluation first. First, rule out the whether he is going into the testicular failure or he is really a hypo because puberty is not achieved. We can treat him with the hormones if required. He is a case of hypo, and then go ahead with the ejaculatory or the TESA part. But directly we can't jump on the TESA part immediately.
Yeah, see, now I'll tell you why Dr. Dalal is saying TISA. There is a role where they say that you probably in the future will be able to get mature sperms after placing this tissue, and just like you have IVM, in vitro maturation, you probably could get sperms out of it. So it is something that a testicular biopsy in a patient who has not started spermatogenesis, you could take with the future in the mind, that probably a system would develop where you could do this. Now, the second important thing which people say, I mean, it's all research based, is that spermatogonial stem cells could be used to make sperms. Now, it has been done in rats. In rats in Japan in I think it was 2012, they had these rats who were uh, azoospermic by busulfan, I think, which they gave to these rats. Then they took out these testes, may say spermatogonial stem cells. They matured them into sperms. They did an ICSI with those sperms, and they were able to have mice. But that has not been possible in humans till now. So probably that's the reason it would be done. I'll just go on to the, just a minute, please. Just a minute. I'll just share, just 1 minute. So now, now I'm going on to the next question here. That's diabetes and smoking, a double hit. So you get so many people who are diabetics who smoke a lot. And these were all lifestyle kind of cases which I had. Now, in case I'll go in fast because I have about 15 cases and we already are 640, 740. So I'd like to complete all of them. And I have phenomenal panelists, so that would be lovely. Dr. Akanksha, I'd like to ask you in this question. Now, you have a person, you've heard in that somebody in the lab is that this is a patient who's a smoker, he's 40-year-old. He's given a semen sample like this, poor morphology, motility low. What is it exactly that you're going to look in this specimen, and how would you optimize this sample if you're doing an ICSI? You'll have to unmute yourself.
Again, this is an ideal candidate for DNA fragmentation. Okay, now if suppose the pickup has already happened and this sample comes to me for ICSI, it's not only for analysis and I have to make use of this sample, I'll probably choose microfluidics as my way for sperm separation. Because it has been shown to, separate the sperm that are DNA wise, that have the DNA intact, so it has a better separation as compared to your normal swim up or density gradient method. So probably I'll put the sample through the microfluidics plate
Now,
to separate it.
I think that's a fantastic answer. Now, which are the microfluidic uh, plates available today, and which is the one which you prefer to use?
Zymot is the one that I prefer to use, although there are many these days, but Zymot is a good one.
A good one, which you prefer to use.
Yes,
Right.
yes, I've had good results with that.
Right. Now, would you like to give any? Now, I'd like to ask the rest of the panelists, would you like to give any antioxidants and do a glycemic control before you take up this patient?
Yes, always.
Yeah,
100%.
yeah,
Yes,
always
definitely.
Right.
antioxidant and good glycemic
Tight
control
glycemic controls.
will,
Right.
reduce the oxidative stress.
So any specific antioxidant that you think would be better than other antioxidants because there's a cocktail of antioxidants available out there?
You asking this question from me?
Yes, sir.
Okay. See, I have about 6 papers on this as well, so I could answer it reasonably okay. Any antioxidant which you give has to be given in complete, number one, proper dose. Number two, it has to be given for a minimum of 3 months. Antioxidants, if you look at the antioxidants, they have a different way of working on the sperm and the ova, all of them. So now if you have coenzyme Q, that works mainly on the mitochondria. So the dose of coenzyme Q is going to be about 300. Nothing less than 300 is going to matter. So what normally happens is in all the cocktails you get, you probably would be getting only 100.
Yes.
So it will not be the correct dose to use. So you have to use 300. Vitamin E, 400 international units. You're going to give these patients, I'm talking of the males, zinc and selenium. If the motility is poor, you could give these patients astaxanthin. So, and folic acid. Now, if anything you need to give, and very few you need to give, you could give vitamin C as well, which is 500. So what normally you need to do is, see, I'll also explain one other thing to you. Vitamin C is very cheap. Vitamin E is very cheap. So most of the drugs which are sold in the market would not be containing them in a proper dose. Not because the dose is cheaper to get, the combining 500 milligrams of vitamin C into a tablet is not possible. So you will have to give these patients a LIMSI or a CC separately.
Okay.
So this is something how you would understand it. And number two, you need to give all these medicines for at least 3 months.
Thank you.
Now,
Thank you so much, sir.
now, let me go on to the next thing. There's a small testes with azoospermia. 31-year-old azoospermic male, normal libido, no systemic disease, volume 8 ml, 32 international unit per liter FSH, testosterone is 3.8, wife is 30. Now, when would you like to do? When do you decide between a micro TSA, a TSA, and a donor sperm?
So, sir, when we talk about micro TSA, it is done in cases of non-obstructive azoospermia where the testicular size is small, so that when you're aspirating it, you're not taking a lot of tissue and damaging the more. And in case,
See, first thing is you don't aspirate in a micro TSA.
I mean, when you extract the tissue, that's what I'm.
Yeah. So I would like to now, why am I asking this question? Because when a patient comes to you and you want to plan, you have to be very clear what you need to offer. What you need to
Sir,
offer.
actually, you have answered this question previously only.
I think I have answered.
Find the
Yes,
cause. What
you
is the
answered
cause
this
of
question
azoospermia?
previously with Dibankar sir when you were discussing about the things.
Yes.
That testicular volume was 6 ml you have got. But
yes.
We should have the center like this. See, you have to counsel patient that there is less probability of getting sperm over here. Then you should get the expert like you, someone who is interested in doing micro TC, who is available, and the clinic must be available. And all the options must be discussed with this patient beforehand, before going on the any procedure. TC, micro TC, or whatever the donor sperm. Donor sperm's option has to be open to this.
Absolutely. So the first thing which needs to be done is judging between the patient being obstructive azoospermia or non-obstructive azoospermia. The second thing which you have to judge is whether what are the chances of retrieval of the sperm, and then you need to speak about the donor sperm to the patient, whatever you are doing in terms of retrieval, after retrieval or with retrieval.
Yes.
Next is IVF failures. Now, a couple with 3 IVF failures, husband oligospermia 2 to 3 million, wife with normal ovarian reserve. So, no genetic investigations have been done in this case. What are the advanced tests which you'd like to get done in this patient?
DNA fragmentation.
Perfect. You'd like to get a DNA fragmentation.
If not previously done as well.
No, yeah, not done previously. Therefore, this is a patient who's
genetic test.
Yes. Now I'm asking you again. Now, see, just this patient has already undergone IVF. By IVF, I mean the patient must have undergone ICSI with a 2 to 3 million. Now, if this patient has not got pregnant and DNA fragmentation is high, when are you going to and when will you plan to take a testicular sperm?
If after 3 months of giving antioxidants, there is no improvement, then probably I'll harvest
See, it's very
sperm
simple.
from
The
the
patient has undergone 3 cycles. The patient most probably has undergone an ICSI. A testicular sperm definitely would have a better DNA in terms of fragmentation. And as it is, it's not difficult to do a testicular sperm. So TSA would be the answer over here. You probably may not need a micro TSA in these patients.
Yeah.
Now, doctor, we have a lot of embryologists with us. Can I have 2 or 3 answers from them? So the first question is, how would you find that a testicular sperm would differ from an epididymal sperm?
The lower or absence of
how would I find means?
No. Fine.
Like if I have.
No. I'm saying, what is the difference which you normally will see in a testicular sperm compared to an epididymal sperm?
Mostly motility.
Lower or absence of motility.
Motility and even maturity. You know, in the testicular sperm, we get more sperms with the cytoplasmic droplet. Although if we get enough number of sperm in the testicular biopsy, we have the option of choosing the ones that look more mature. Definitely the epididymal sperm are more motile as compared to the testicular sperm. So that is the difference that we see between testicular and epididymal.
So it's so important for us to understand that even if the sperm doesn't have a good motility from a testicular sperm, it is better in terms of DNA than an epididymal sperm.
That's
So,
correct, yes.
so this is something which needs to be kept in mind, because a lot of times you may feel that a motile sperm would probably be better than a non-motile sperm. So that's why a testicular sperm, this is something which we need to understand over here. So next is varicocele. So there's a man who is with 12 million count, AMH 0.8, wife is 34, and a palpable varicocele. Now, it's a question which uh, comes into a lot of controversy whether this patient should be, whether we should wait for surgery and go directly for ART.
ART, sir.
Sir, ART is because it's
Varicocelectomy.
EMH is already
Considering
0.8.
my age
Varicocelectomy.
and
Surgery.
Varicocelectomy.
See,
Palpable varicocele, abnormal semen parameters, infertility, all three are pointing towards varicocelectomy.
Rutvij, this is the
But
perfect.
I see that the wife is already
Yes,
34
Wife
and she
is
has
wife
an
is
AMH
34
of,
and the
so
0.8
if it
AMH.
was
See,
a younger wife,
American American Neurological Association recommends varicocelectomy in this case. Plain and simple.
but we have
So
to also
If you
consider
want
how
to
the
wait for
wife is,
In
right?
the varicocele repair, the sperm quality will increase. Health of the sperm will
Will
increase.
definitely help.
No, it will help the semen quality fine, but then if we lose out on the eggs, then what is the point? Then
Hardly
ultimately
take
we might have to
it
go in
hardly
3 months. We wait for 3 months.
10
AMH is
15
already
days. So
0.8. We
see,
don't know the graph with which the
I
AMH
don't
is
think we are
declining for this
missing out.
patient.
I think it's a beautiful question, and I love to see Akanksha and Rutvij debate.
I would still do a varicocelectomy.
The
And
only thing here is the not even AMH, but the age of the patient is important
So this is
part.
happening every
I
day.
know, I know, I
you
know.
need to counsel the
Both the
patient also.
female and
Rather,
male
it's not
factor is
necessary after
compromised.
6 months you will
Age of the patient is important part, sir. Not
See,
even AMH. AMH of 0.6 or 0.5 also can conceive naturally with the normal semen parameters, which Rutvik is talking about.
I think what we need to do is do a DNA fragmentation of this. If the DNA fragmentation comes as fine, then with a 0.8 AMH, we could go ahead for an ICSI right away. Or actually, if the DNA fragmentation is down, 3 months down the line, operate immediately for the varicocele. It should be done a microsurgical varicocelectomy, saving the testicular artery. And once this is done, we could go ahead for an ICSI. The only catch is that the AMH is 0.8, and therefore a very, very judicious thought process needs to be put into it. Now, another advantage which happens is in an AMH of 0.8 at 34 years, it's another question and catch to it. Rutvij will be a beautiful person to answer this. How many people today, the way people function, would say we'll try for your own egg?
Many.
Many, sir.
Many. The second question is, if many say we'll try for your own egg, after the retrieval, if people would go ahead for a second cycle if she doesn't have a baby, then probably going ahead, doing a varicocele surgery, in case the DNA fragmentation is not high, is fine, going ahead immediately, or whatever, once you do a varicocele surgery, in any case is going to help even for the second cycle, because you need 3 to 6 months for this. So in any case, a varicocele surgery could help in this patient. Now, should we wait? Now, next is just a minute. Now, there's a cancer survival, 30-year-old Hodgkin lymphoma survival, post chemo, now azoospermic. Now, what are the real world options for this man?
If fertility preservation has been advised prior to the chemo, then we can utilize the same sample. If
Sir,
there
it's very unfortunate. It's very unfortunate that most of the cancer centers don't think of children for these people.
Yes.
And number one. And the second thing is, at that time, they are not just counseled.
Yes.
Most of the people who come to you are post survivors.
So then
donor sperms. Donor
No.
sperm is the only option.
No. A lot of these patients, after about a year of chemo, if optimized for their testosterone, you can recover sperms and give them babies. There are a lot of these post-cancer survivors who can have their own sperms, a large number. And if not possible, then you would go ahead with this, with a donor sperm. But otherwise, the best option always is to cryopreserve their sperms. Another question. I'm asking this question from my panelists. What about egg preservation?
We always have the same thing. Even I have been made by many clinicians.
So when
Hello?
it comes to fertility preservation, why should it be only sperm? We should also freeze eggs.
नहीं नहीं वो तो आपकी आवाज के अंदर का जोर बता रहा है कि आदमियों की अकेली बात क्यों की जाए.
But you see, you brought
नहीं
out the
नहीं
topic of egg
no
preservation.
So egg preservation in
no
which case, right, doctor?
I'm asking this, which are the patients and which cancers would you like to preserve eggs?
The
Which are the
breast carcinoma is the most common, which we are getting the patients for the oocyte preservation.
right. So there are a lot of ifs and buts in fertility preservation. I don't get too many patients, so I really will not be able to answer this question of because people who undergo cancer or get breast cancer or anything in young age, they normally do not get the eggs preserved. But I think the most common cause of egg preservation normally is in the breast cancer.
Breast cancer.
I'd like to ask you one question about retrograde ejaculation. 38-year-old man, diabetic with retrograde ejaculation. Somebody's mic is on. Hello? I'll just check.
Yeah, I think somebody AS, the mic is on. Yeah.
Okay. Now the mic is off. So we could go on to retrograde ejaculation. Now I'd like to know that there's a man with retrograde ejaculation. How will you exactly manage it?
Sir, I think Akanksha has recently
Yeah,
managed one patient, so she'll be the right person to talk about it.
हाँ
So
जी
what we did
आकांक्षा जी
was
बताइए.
that in such a patient, we asked the patient to just drink this soda. You can give sodium bicarbonate tablets, but if you have baking soda at home, that works very well. So have a teaspoon of baking soda twice a day mixed in water. We gave a litmus paper to the patient. Okay, we gave a litmus paper to the patient and we asked him to keep checking his urine. All right. When the urine turns basic, then we asked the patient to come to the center. Okay. Patient came to the center. We asked him to void the bladder completely. Once the bladder was voided, we asked him to try to collect the sample by the normal method, by masturbation. Okay. Now he felt like he has ejaculated, but he actually didn't because the sperm had gone retrograde into the bladder. Then we asked him to urinate again, this time in a cup. Okay. So now because the bladder was already voided, the quantity of urine that came this time was only about 15 to 20 ml. We spun this entire urine and we got a pellet at the base. This pellet we collected and we centrifuged it again in the sperm wash media. We washed this pellet twice. We were able to get motile sperm. We were able to achieve about 85% embryo fertilization, and the patient got pregnant in the first shot.
Great. So now what we normally would do is give the patient dapsonil imipramine. Normally you would give it for a month. A few patients of retrograde ejaculation are able to get this sperm count by imipramine, 25 milligram of dapsonil. If they do not get, then Dr. Kanksha has beautifully explained the method of alkalinizing the urine, emptying the bladder, masturbating, giving a sample, centrifuging and taking out sperms. But if not available, then electroejaculation would be the way out, or for that matter, at times sperm retrieval. So I think it is great that these people are taken care of. Now, there's a hepatitis B positive male. How do we protect the female partner and the baby?
Vaccination and protection with the sexual activities. Vaccination is the priority for the female partner. Uh, if she is not vaccinated, then vaccinate for the 3 doses. And during intercourse, take in the protection. And post vaccination, we should monitor the antibodies. And level of antibodies is, if more than 10 MIU, then it means it is immune.
Now, what are the laboratory safety precautions which need to be taken? Dr. Akanksha?
I'm sorry, I think I got disconnected from what was, I'm sorry, what?
What are the laboratory uh, safety precautions which need to be taken in a hepatitis B sample?
Uh, so normally we should treat all samples like biohazards. But what we need to do is that basically whenever we are handling any sample which has a known viral load, then we tend to use PPE. Normally, we keep this patients as the last of the day. We use all the protective devices like your PPE, double gloving, and a glass, and we process this sample. And once the sample is processed, we discard everything and we clean everything with sterilization. That's basically what we do in the lab.
Density gradient is what you would prefer, right?
For processing of the sample,
Yes.
Yeah.
yes, definitely density gradient. Although there is no semen preparation method that guarantees complete removal of the virus,
Right.
if I get such a sample, I would definitely prefer density gradient over the normal semen method.
Right.
And the embryo
So,
freezing you do in the separate tanks or in the same tank?
Separate tanks. Although we can't have separated tanks for each and every virus, but we keep a separate tank for any
Infected
kind of
people.
viral load carrying samples. So we have that. Although transmission through nitrogen has never been reported, but we just don't take that chance.
great. So now, couples with severe oligospermia, despite counseling, insist on repeated IUI because somebody has told them, मैं IUI ही करूंगी, and they say मैं IUI ही कराऊंगा. ऐसी कंडीशन में आप क्या करेंगे?
So showing them the data that after 3 cycles of IUI, the result is very poor, and proper counseling.
I think
to tell them that.
I think there are a lot of patients who come like that, and to explain to them with a firm counseling is very important. Keeping in mind, even if they leave you, it doesn't matter.
Yeah.
Because that's what they need to know. Now,
Because
the next is
if you don't give them result, then you're also a bad doctor in front of them. So you have to. It's fine if
absolutely,
they go then.
absolutely. Now, a husband refuses semen testing, says problem is with my wife. What do you talk to them? What do you say to them?
That it's only 40% female, 40% male, and 20% unexplained. So they need to know that it can be you. It can be the male also, which can be responsible for.
And you've got to tell them it's a very nice place where you can give your sample. And you could, in case not be, they would say that normally I can't give a sample like this.
Yeah.
So you could take your wife into the room and probably give a masturbation sample.
Yeah.
So this is another thing which makes them a bit comfortable. Men
Right.
are very delicate, though they may feel anything like that, but बड़े छुई मुई से delicate से होते हैं जब semen sample देने को आता है. अब stem cell couples educated read online about stem cells and AI-based sperm sorting. Now, is it hype or is it hope?
It's still in the
It is
experimental
hope.
phase.
The start.
Yeah.
Right. So they need to be told it's experimental. Just like today, robotic surgery is being done for everything. I mean, every patient thinks कि robot आया और उसने surgery करके चला गया. But I mean, this is the truth. I get patients who want every robotic surgery. A robotic varicocele. Have you ever heard of a robotic cesarean section? Believe me, there is so much of hype which has been created that not a cesarean section, but yes, it is there. Similarly for stem cells. So now, in the end, I would say I've had a lovely panel, lovely guests which we've had, and we've spoken about so many things. Male infertility is treatable, ART is to be used, but couples need science, hope, and sensitivity. And thank you very much. Thank you very much for the long panel which we've had. It's been a pleasure to be with everybody. I mean,
Thank you so much, sir. Thank you so much.
and you know,
Thank
my
you so
friends,
much, sir.
it
Thank you
is.
for the wonderful panel. Thank you,
Oh,
sir.
thank you very much. And you know what? It's lovely meeting everybody on a panel. मतलब वैसे तो मिलते ही हैं, पर यहाँ मिलने में बड़ा अच्छा लगता है. So thank you very much, and thank you, Dr. Monica, for inviting me, and the whole team which is here of ISAR, which has invited. Thank you very much.
Thank you, Jindal sir. Thank you, Dr. Banerjee, and thank you, all the wonderful panelists. The panel was really icing on the cake after the two wonderful lectures. And Sunil Jindal sir ka jo tadka, that that typical tadka is there, all with the studio and the mic and everything. So I'm really happy to have you all, and we have ended this very nicely with a small announcement that our next 5.0 would be on poor ovarian reserve, and the date proposed is 24th of September. So we look forward to another great webinar. All suggestions for the best speakers in India are welcome. So thank you, BSV team. Thank you, all conveners and my coordinators. Of course, today they are missing. I don't know how. So probably they are so, content, Garima, that all of us are handling. They are having holiday. So thank you, Team BSV. Thank you. Acha, somebody's there, I think. So thank you, Priyanka. Thank you, Anmol, Deepak, Team BSV, whoever has worked, Rubia, to have done a wonderful, given us a good platform. And anything you want to say, Garima, to end the thing?
I think, ma'am, it's truly a perfection series with the perfectionist convener, with the perfectionist speakers, moderators, and an august panelist. What else I do say? Every webinar that we have been doing is a new learning curve from really the stalwarts of the country. And thank you everyone for accepting our invite, sharing your wonderful insights. And as Madam said, we are very soon coming up with the next one on the poor reserve, from back to the sperm to the egg. So thank you once again.
Keep shuttling between
Thank
the
you.
egg and the sperm, with
Yes,
sometimes.
sir. Sunil sir wants to say
No,
something.
I'm just saying thank you very much. Thank you very much, everybody. And I think it's been lovely. Thank you very much.
Thank you,
Thank you, Monica madam. Thank you,
Thank you so
everyone.
much.
There'll
Thank
be a certificate of attendance for whoever wants to download. It will be mailed to you all. And another announcement, if your friends or colleagues or you want to watch this webinar again, it's there on YouTube. You can always go to the YouTube link and watch it.
you.
Thank you so
Thank you
much.
so much.
Thank
Thank
you
you.
so much. And have a great weekend.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye. Good night.
Good night.
Bye, Garima.
Bye, ma'am.
Bye.